Okay, so we'll start here with chapter 3, all about reproduction. All right, can you guys see this PowerPoint here?
Yes.
Yeah, we can
Okay.
see it.
Yes.
Okay, let me try to make it bigger. All right, that look okay for everyone?
If anybody has questions or anything, please, say something, okay? 'Cause
Yeah.
if we don't know you have questions, we can help you, okay?
Yeah, I can't see anything in the chat while I have my PowerPoints up either. So just take yourself off mute if you do have a question. All right, let's get into it. So I told you we're going back to health class here. So sexual development begins at conception. So this is a really interesting little fact that I didn't know until I started teaching this course. But when we think about how a person's sex is determined, it's actually determined at the moment of conception. And conception is when the sperm meets the egg. So that union is called conception. So for a female, our sex chromosome, or our sex, what am I trying to say? Our sex, Nicole, what am I trying to say?
You're talking about the union of the egg and the sperm?
Yeah, so we have eggs. I'm having a moment right now. So we have
The
eggs,
ova?
and males have sperm, and
Yes.
all of our ovum, or all of our eggs, have an X chromosome. They all are the same. They're all X. Whereas males, each one of their sperm carries either an X or a Y chromosome. So it depends on if an X or a Y fertilizes that ovum, and that's how we determine the sex of the baby that will then develop. So we see here on the bottom, if an X sperm fertilizes an X egg, that gives us XX for that person's chromosomes, and that is a female. Whereas a Y sperm meeting an X egg would give us a male. XY is male. So that happens right at conception. Kind of cool. Okay, and then I'm sure we all know, so puberty is the time when our reproductive organs are fully functional. We develop those secondary sex characteristics. Puberty isn't like a single event where all of a sudden you wake up and everything's mature. It's a series of changes that happens over time. Kind of what's happening in the body is the hypothalamus is stimulating the anterior pituitary gland. There are certain hormones that are produced, and then that's kind of where those changes kind of happen, and that slow series of changes happens over time until everything is mature. So here's just a table from your book about secondary sex characteristics. So for females, we have breast development. We have fat that's deposited on the breasts, the thighs, and the buttocks. The pelvis becomes wide and round. We develop pubic hair and axillary hair, armpit hair. The skin becomes more smooth. The voice changes to a more high-pitched voice, whereas males, they develop about 50% more muscle mass. They have a more narrow, upright, heavier pelvis. They also get pubic and axillary hair, as well as facial and chest hair. Their skin becomes more coarser, and their voice begins to deepen. Okay, so let's talk a little bit about just general anatomy. So one thing that kind of surprised me when I started working labor and delivery is how many of my patients didn't really know much about their own anatomy. And so if this is something that no one really ever talked to you about, or maybe was a taboo thing in your household, you didn't know a whole lot about your own anatomy. I had a lot of patients who didn't understand that they had an opening where their urine came out of, an opening where the baby came out of, and an opening where their stool came out of. So I think it's just really important that we understand the anatomy, and that's something that we can always teach our patients as well and make them comfortable with that conversation. So The first word is vulva. So vulva is just kind of a collective term for the external reproductive organ. So I feel like a lot of times when people say vagina, what they're actually meaning is the vulva. So like when you look at that area, that is the vulva. The mons pubis is going to be the kind of like that fat pad over the pubic bone where a lot of pubic hair grows. That's called the mons pubis, and it helps to kind of add a little bit of layer of protection to that pubic bone or that symphysis pubis. And then labia. So labia are comparable to what the scrotum is in a male. We have the labia majora and the labia minora. And then we have the clitoris and the prepuce. So this would be comparable to the head of the penis. So it's very sensitive. The prepuce is what covers, it's like the hood of the clitoris. And then the perineum is going to be the area between the vulva and the anus. So we'll talk about the perineum when we get to like labor and delivery, and we talk about like tears that you can have. Sometimes that area, that perineum, can tear during childbirth. All right, so this is just from your book here, so you have a little visual of everything we just talked about. Okay, so internal structures. So the ovaries. Ovaries are what store our ova or our eggs. We'll talk a lot about what the ovaries are doing with the menstrual cycle. So the ovaries do secrete estrogen and progesterone. They receive signals from the anterior pituitary, and that kind of helps this whole menstrual cycle that we're going to talk about. These signals get sent to the ovaries, and then the ovaries start doing their thing, which we'll get into. And then the fallopian tubes, these are muscular tubes. They lie near the ovaries. It's actually not connected. The fallopian tubes are connected to the uterus, but they are not directly connected to the ovaries. And they help to propel the ova from the ovaries to the uterus. So we'll talk a little bit more about that as well. And then the uterus is, it's very muscular. It's the pear-shaped organ that holds a developing fetus. And it's also where we menstruate from. So the lining, that inner lining or endometrium, is what we shed each month when we have a period. Other parts of the uterus. So the fundus is that very top part of the uterus. It's the most musculature and strong. It's where a lot of the contractions, the main force of the contraction is coming from the fundus or the top of the uterus. Then we have this funny word, isthmus. That is located near the lower part of the uterus. It's where the uterus meets the cervix, and it's much thinner than the fundus. That's the isthmus. The cervix is what it opens from the vaginal canal into the uterus. So it's like a little neck. There's an internal opening and an external opening. And a typical cervix is somewhere between 3 to 4 centimeters long. It's a tube. And then the layers of the uterus. We have the perimetrium, so that's the outside layer that covers the body of the uterus. The myometrium is the muscular layer, so myo means muscular, so that's the kind of the inside muscular structure. And then the endometrium is that inner layer that we shed each month when we have a period. Okay, so just another visual so you can see all the things that we just talked about. Let me get out of my full screen. Can you guys see my cursor?
Yes.
Okay, so this picture here, it shows you the ovary and the fallopian tube. It makes you think that these are connected structures, but they're actually not. What happens is when we ovulate, when we have one of these eggs in here, we'll talk a little bit more about that process of ovulation, but when one of these eggs gets released, these little finger-like projections, they look like little fingers on the fallopian tube, actually go around to find that ovary, and they pull that egg into the fallopian tube. It's really remarkable that they're able to do that. there's all these little hairs inside this tube that help propel that egg towards the uterus. Usually when we talk about conception, so where sperm would meet that egg, it's going to happen somewhere right in here. This is called the ampulla. So this is where conception will typically happen, and then that egg will gradually make its way into the uterus. So the uterine components that we just talked about, the fundus is this top part here. Down here at the bottom where it kind of thins out is the isthmus. And then here is our cervix, that tube that enters into the uterus. This also shows you the different layers that we talked about. So we've got the perimetrium on the outside, the myometrium on the inside, the muscle, and then the endometrium, which is the inner layer. And then there's all these ligaments and structures that kind of hold that organ in place in the pelvis. And this is just a sideways view, so you can see kind of how everything sits in the pelvis. So here's the rectum, here's the uterus, here's the bladder. Okay, so we'll talk a little bit about some support structures. So the pelvis, we talk a lot about when we think about the labor and delivery process. So just to kind of get you guys familiar with that. So the pelvis is the lower end of the spine, or connects to the lower end of the spine. When we talk about the pelvis, we want to refer to the true pelvis and not the false pelvis. So the false pelvis here in pink is that top part, which doesn't really have anything to do with childbirth. It's not as important as the inlet or the true pelvis. So the shape in here is really important to childbirth, because if you have a different shape, we'll talk about the different shapes that there can be, it can really change the outcome of the baby being able to be born vaginally. Babies have to make all of these rotations down into the pelvis, and their heads have to be in certain positions to be able to fit down into that pelvis. So this true pelvis is very important, whereas the false pelvis doesn't really change a whole lot. And then in that other picture, I showed you kind of the muscles that are holding everything in place, the ligaments. These ligaments, if anybody's been pregnant or have talked to somebody who's been pregnant, they may tell you about round ligament pain. So the round ligaments are certain ligaments that help to support that uterus. And so as the uterus is growing and stretching, it also stretches on those round ligaments. And it can be very, very uncomfortable. So a lot of times your patient will report like a really sharp, intense, one-sided pain. Maybe they were laying in bed and they turned to their right side and all of a sudden they had this shooting pain on their right side. Typically that's round ligament pain. It's very sharp, it's very quick, it's self-limiting, but people get scared. It's very uncomfortable, but it shouldn't be uncomfortable for a long period of time. Usually it's a couple minutes and then it's completely gone, but that's what they're feeling, is that stretching and pulling of those ligaments. So just more pictures of, this is that same one we just looked at, but showing you the different ligaments and then the muscles that kind of hold everything in place. Okay, let's talk about the menstrual cycle. So we are going to break this down into what the ovaries are doing and then what the uterus is doing. These things are happening simultaneously, but it's nice to kind of break them down and to see what each is doing separately. So I mentioned how we have certain hormones. So we have the anterior pituitary that kind of governs all of this. So the anterior pituitary gets signals from the hypothalamus, which releases this GnRH, gonadotropin releasing hormone. It releases that, it sends these signals to the anterior pituitary, and then the anterior pituitary releases its own hormones that then stimulate certain things. So like for the female, they have follicle stimulating hormone that's released from the anterior pituitary. This is what tells the ovaries to go ahead and start that process of developing a follicle and getting ready to ovulate. So we're going to break down kind of that whole process. It also releases luteinizing hormone. We'll talk about what that does in the menstrual cycle. And then this also happens for males as well. So males also get follicle stimulating hormone, which helps them to produce sperm. And then they have something called interstitial cell stimulating hormone that helps with their testosterone. We're not really going to dive a whole lot into male reproduction. I'll cover just a teeny little bit, but mostly we're going to talk about from a female perspective. Okay, so let's start with the ovaries. What's happening in the ovaries each month? So we have these cyclical changes that occur in response to those two hormones that I just mentioned, that follicle stimulating hormone or FSH and luteinizing hormone, LH. Both of these hormones are coming from the anterior pituitary gland. When we talk about the ovarian cycle, there are two phases of it. So right now, before I start this whole thing, this is like the textbook menstrual cycle. This is that 28-day menstrual cycle. Anybody who is a woman knows that we do not all have 28-day beautiful textbook menstrual cycles, but for the sake of learning about the menstrual cycle, we're just going to pretend here. So a perfect textbook menstrual cycle is 28 days. So it is broken down into two phases. The first half, or the first 14 days, is the follicular phase. So first is follicular, FF, and it's controlled by follicle stimulating hormone. So follicular, follicle, first. So just kind of remember it that way. First 14 days is the follicular phase controlled by follicle stimulating hormone. Whoa, I can't even say that. You guys say that. And then the second half is the luteal phase. So the second half occurs after ovulation. So after we release that mature egg, now we are in our luteal phase, which is controlled by luteinizing hormone, and that's days 15 through 28. So luteal phase, luteinizing hormone, last phase, LLL. Okay, so let's talk a little bit more about that first phase, the follicular phase. This is the first 14 days. What's happening in that ovary? Well, we have follicles. A follicle, I like to think of as like a little house that's holding an immature egg. So each month, our body picks one follicle to become like the dominant follicle, because there's a bunch of them in there, but one is going to be like the one that we want to use, and that's the one that we're going to put all of our efforts into. So that follicle begins to develop because we have this rising FSH from the anterior pituitary. So we're getting this big surge of FSH. This follicle's like, okay, it's my time to shine. It starts to develop, and that egg inside of there starts to mature and get bigger, and it's in preparation to be released or to ovulate. Once that follicle gets large enough, it starts to produce estrogen. The follicle itself starts to produce estrogen. That estrogen is able to signal back to the anterior pituitary, okay, we've got enough estrogen now. This egg is ready. It's nice and mature. This follicle's good to go. So then the anterior pituitary releases a big surge of LH, or luteinizing hormone. That big surge of LH is what causes ovulation. Ovulation is where that mature egg comes out of that follicle, out of that little house, and it goes out to get picked up by the fallopian tube. So those fimbriae, which are those finger-like projections, pull that egg into the fallopian tube. So ovulation is when that follicle opens up and releases that mature egg, and that all happened because it had this big surge of LH. Okay, now that we have ovulated, we're in the second half of that ovarian cycle. So now we're in the luteal phase. So we have luteinizing hormone that's elevated. That's what caused that follicle to open up and for that egg to get released. That LH remains elevated. Now that follicle that was holding that egg starts to transform into what's called a corpus luteum. So it gets a new name. Now that it doesn't have that mature egg in it anymore, the follicle develops into what's called a corpus luteum. The corpus luteum begins producing progesterone. Now, if a sperm never meets the egg, so we don't have any fertilization, there's no fertilization, that corpus luteum just degenerates, it dissolves. And with that, our estrogen and our progesterone levels plummet, and that tells our body, okay, we've got to go ahead and have a period and start over again. And that leads back to day 1 of a menstrual cycle. Okay, this is my favorite cartoon that kind of breaks it down, I think in a nice, or I don't know if it's a nice, easy way, but a better way to kind of understand what's happening. So when we're talking about the menstrual cycle and what's happening with our ovaries, day 1, so this is the start of a menstrual cycle. The first day that you bleed of your period, that's considered day 1 of that menstrual cycle. So day 1, we have low estrogen, we have low progesterone. That tells our body, okay, we've got to shed this endometrium, we've got to shed that inner lining. So we're bleeding here. Gradually, as we make our way into the menstrual cycle, day 4, day 5, our little follicle, this is a little follicle here, starts to get some signals from our anterior pituitary. It's releasing that follicle stimulating hormone. And it's like, okay, I'm the chosen one. I'm going to get bigger. I've got an egg inside of here that I'm maturing. I'm getting bigger. I'm so big now that I am releasing my own estrogen, and I'm sending signals back to the anterior pituitary that it's time to go ahead and release that big surge of LH. So the anterior pituitary releases that big surge of LH, and then it comes down here and it whacks that egg out of that follicle. So that's what you're seeing here. There's the follicle, it spits out the egg. That's ovulation. Now we're in our luteal phase since we've ovulated. Now our follicle is called a corpus luteum. Remember, it gets a name change. And our corpus luteum starts to secrete progesterone. Now, if this corpus luteum doesn't get signals that that egg and sperm met, maybe fertilization didn't happen and we're just going to go back into a menstrual cycle, then that corpus luteum starts to get smaller and smaller. It actually gets another name. I don't care if you guys know corpus albicans, but basically it just degenerates. It gets smaller. Estrogen and progesterone levels plummet, and that leads back to day 1 of the menstrual cycle. We bleed again. So that kind of shows you what's happening in the body from the ovarian standpoint. Does that make sense before I keep going? Told you guys we were getting deep into the menstrual cycle today. Okay. So when you're studying, think about this cartoon. Okay, this is from your book. It's just another way to kind of have a visualization. So this is actually showing you 2 periods back to back, like 2 months back to back. So this shows you, like, here's your anterior pituitary. It shows you that's releasing that FSH. It shows you the follicle that's getting bigger, and then it releases that egg around day 14. And then that follicle turns into the corpus luteum, gradually gets smaller and smaller. And then this kind of shows you what the hormones are doing. So as that follicle gets larger, it starts to secrete estrogen. And then eventually that corpus luteum starts to secrete progesterone. So just another way to look at things. I like a fun cartoon personally, but if this helps you, fantastic. There's a little video here if you guys want to go back and watch. Throughout my PowerPoints, you may see some videos. We don't typically have time to watch them, but they're good little reference if you want to go and watch. They're usually pretty short, like a couple minutes, but this is just a video on ovulation. So, and just a reminder that that big surge of luteinizing hormone, or LH, is what causes ovulation. Okay, so we kind of talked about what's happening in our ovaries. While that's happening, simultaneously, there's something else happening in our uterus. So I wanted to kind of tell you a little bit about the anatomy and the layers of the uterus so you kind of understood a little bit more about this part. So the endometrial or uterine cycle, those words can be interchanged, is what's happening at the same time that our ovaries are going through that process that we just talked about. So with our uterine cycle, we have 4 different phases. We have the menstrual phase, proliferative phase, secretory, and then ischemic. So let's talk about what each one of those are. Okay, so our first phase is the menstrual phase. So I said that when you start your period, that first day of bleeding is considered day 1. So during your menstrual phase is when you're having your menstrual cycle, when you're bleeding. So day 1 is when you start bleeding. So approximately 2 days before this phase starts, that's when we have those low estrogen and progesterone levels, which causes vasospasms of that endometrial lining. The blood supply there starts to become ischemic and necrotic. So all those blood vessels no longer are functioning. And so then our body knows that it's time to get rid of that lining. It sloths off that lining or sheds that lining because we have low levels of progesterone and estrogen. Those blood vessels are no longer functioning. So we need to go ahead and start over with a new lining. So during our menstrual phase, so when we're on our period, a new follicle is already starting to develop again. We're starting that process over immediately. Even though we're having our period, a follicle is beginning to develop. It's the chosen one. It has that immature ovum that it's going to start working to become mature and do the whole thing over again. Once that follicle gets large enough, it's going to produce that estrogen. So during this menstrual phase, it's about 5 days. So for some women, they're bleeding all 5 of those days. For some, they may only bleed 3 days. For some women, they may bleed for 8 days. So it's all different, but this is just the average is about 5 days. And then also the average amount of blood loss is about 40 milliliters. Some women are mildly anemic because of this blood loss. And of course, I'm sure we all know, or you may personally be somebody who bleeds much more than this as well. Okay, so then after our menstrual phase, the next phase that we go into is the proliferative phase. So this starts around day 5 into our menstrual cycle, and it lasts all the way up to ovulation. So what's happening is the endometrium, which is the uterine lining, is starting to regenerate because we have estrogen levels that are becoming higher and higher. We have new blood vessels that are forming, and we are preparing that lining for a possible pregnancy, a possible implantation. That's where we have the sperm and the egg. If they've met and they make their way into the uterus, it implants into that uterine lining. So we'll talk more about implantation here in the future. What's also happening is our cervical mucus. So we have cervical mucus that changes throughout the menstrual cycle. When we are close to ovulation and when we are ovulating, our cervical mucus changes and it becomes thin and clear and stretchy and more alkaline, which is more favorable to sperm. So it helps those sperm be able to move up through the cervix, into the uterus, into the fallopian tube to try to fertilize that egg. Okay, so then after ovulation, we are now in our secretory phase. So this begins at ovulation to about 3 days before our next menstrual period. What's happening during the secretory phase is that our endometrium, or that lining, continues to thicken and it becomes really vascular because we have high progesterone, we have high estrogen, and it's hoping that there's going to be a pregnancy that develops. Progesterone is what causes that endometrium to really thicken up, and it helps to secrete substances that can nourish that fertilized ovum. So if pregnancy were to occur, it just has this like perfect little environment for this baby that could possibly develop. Okay, so let's say fertilization did not happen, a sperm did not meet that egg. Now we go into our ischemic phase. So that corpus luteum begins to degenerate, our estrogen and progesterone levels drop all the way back down, our uterine lining becomes ischemic, starts to shed, and now we're back to the menstrual phase. So we go all the way back to day 1. So that same picture again, but now I've included down here what's happening with the endometrium. So when you are on your period during the menstrual phase, you're shedding that lining, and then gradually it starts to build back up. We ovulate here, it's building back up, and then if a sperm and an egg did not meet, then it's going to go ahead and drop back down, and we're going to go into another period. So this is showing you what's happening with the ovaries and what's happening with the uterus. So you can kind of compare and contrast. So the menstrual phase and the proliferative phase correlate with the follicular phase of the ovaries. And then your secretory phase and ischemic phase correlate with the luteal phase. Okay, does that make sense? What's happening with the ovaries and what's happening with the uterus? I know it's a lot.
Yes.
All right. All right, so we'll talk about a few other little things, and I've already mentioned some of these hormones. So at the beginning, I had mentioned how the hypothalamus is secreting that GnRH, which is what tells the anterior pituitary to release the follicle stimulating hormone and the luteinizing hormone. We talked about FSH, which also comes from the anterior pituitary, the LH, which comes from the anterior pituitary. Estrogen is what's coming from our ovaries, and progesterone is what's coming from our corpus luteum, which is that new name for that follicle. We also may talk a little bit about prostaglandins. These aren't technically hormones. It's more of like an inflammatory process. It's what we think, we don't know for sure, but what we think is the cause of like menstrual cramps and pain. We think it correlates with these prostaglandins, but we still don't quite understand why some people have super, super painful menstrual cramps and others don't. Sometimes there's medical conditions, which we'll talk about, but some people just have like primary dysmenorrhea, which is just painful periods without an actual like identifiable cause. Okay, so I had mentioned cervical mucus and how it changes throughout the menstrual cycle. So typically the mucus of the cervix is scant, it's thick, it's sticky. So it's not like great when sperm are trying to like get through there. It's not great for their motility. It's a little bit more acidic, and so the sperm don't handle that well. Whereas during ovulation, all of that changes and that mucus becomes thin and clear and kind of stretchy, and that allows those sperm to make their way up into the uterus. That particular mucus, sorry, I know the word mucus is like such a gross word. I don't have another word for it, but it has a special name when you're ovulating. That's called Spenbarkete. It's just like a fancy way of saying what your cervical mucus looks like during ovulation, Spenbarkete. So some women, they actually use that as their like method of birth control. They will monitor their cervical mucus, and they are looking for this Spenbarkete, or they're looking for when it starts to thin out, and then they will either have sex during that time if they're wanting to have a baby, or they will avoid sex if they do not want to have a baby. So it's a way to use like a natural birth control method. So here's just a picture so you can have an idea. So most of the time, our mucus looks like this. And then as we reach towards when we ovulate, it's going to be thin and stretchy. Okay, talk a little bit about the breasts. So our mammary glands are not directly functional with reproduction, but of course we know that when we have a child, they can be used for breastfeeding. During pregnancy, we have the placenta actually secretes estrogen and progesterone, which helps to develop our mammary glands and gets them ready for breastfeeding if that's something that that woman chooses to do. So as far as the function, they are inactive until puberty, and then estrogen will stimulate the growth. Fat is deposited in the breast, and that's the major determinant of size. Something that's interesting, though, the glandular tissue, so like the tissue that produces and holds like breast milk, is pretty much the same for all women. So regardless of breast size, we all pretty much have the same amount of glandular tissue. So just because somebody has smaller breasts does not mean that they cannot breastfeed. I just thought that was kind of an interesting little fact. So what's happening is prolactin is secreted by the anterior pituitary, and that's what stimulates milk production during pregnancy. When we are pregnant, though, the estrogen and progesterone that our placenta produces actually keeps that prolactin kind of at bay, so it inhibits it. So that's why we don't make milk during pregnancy. But once the placenta is expelled after birth, then we no longer have that estrogen and progesterone from the placenta, so now that prolactin is able to kick in and actually make the milk. So that just shows you inside of a breast and the glandular tissue. To be considered actually menopausal, you have had to go an entire year or 12 months with absolutely no vaginal bleeding, no periods whatsoever. And at that point, you're considered menopausal. Now, if you do out cancer, that's kind of a warning sign that something may be wrong. It doesn't necessarily mean that you've got cancer. There's other things that can cause it, but definitely a cause for concern if you are menopausal and you are now having vaginal bleeding. Okay, and then just a little bit about male reproduction. So external organs, we've got the penis and we've got the scrotum. So our penis is used for outlet for urine and sperm. Scrotum is what protects the testes, and it also helps to keep the testes at a good temperature. So there's a muscle that males have called the cremaster muscle that helps to either raise the testes or lower the testes depending on the temperature. And that way it keeps the sperm at the perfect temperature, and so that they're not getting overheated or they're not too cold. Sperm are very sensitive to temperature changes. So actually inside of the testes, so sperm starts out in the seminiferous tubules, and then these are kind of like your immature sperm, and then they make their way up into the epididymis, and this is where they become mature sperm. And then this is the spermatic cord here, which includes like the vas deferens. So if anybody is familiar with like a vasectomy, that's the vas deferens is what is cut during a vasectomy. So they still have semen. There's just not sperm within the semen. But always get your vasectomy checked, because I've had so many people tell me that their man got a vasectomy and then they got pregnant because they didn't go back and check to make sure that they weren't still somehow producing sperm. And then accessory glands, yeah, go ahead.
Megan, I'm sorry. I just want to interject. Yes, guys, Miss Siska did freeze for a minute. What I wanted to clarify was when she was saying about uterine bleeding. So uterine bleeding, when outside of menses, if it's not within the menstrual period, if it's heavier than like normal, it can be problematic. Like they might consider it to be like even like outside, like with like I'm sorry, advanced maternal age, like they might think it's like uterine cancer or something like that, so they would look further into it. That's what she was talking about.
Yeah. They'll do
So,
biopsies or for like ultrasounds, different things like that to figure out why you're having this atypical bleeding.
right. So, sorry, I
You're
was
fine.
trying to think back of what the
No,
PowerPoint
all
said, and that's what I'm stuttering on myself, but
it's
that's
okay.
what it was saying. Sorry, guys.
No, story of my life. Shoot. Okay. All right. So, oops, let me go back here. So, as far as the male accessory glands, so the seminal vesicles, prostate, and Cowper's gland, all of those different glands, they all do something a little bit different, but they also help aid in sperm. Like feeding the sperm, nourishing the sperm. They produce a fluid to protect the sperm. So the whole point is to make these sperm ready to hopefully participate in the whole menstrual cycle that we just talked about. Like I said, sperm are very particular. They have to have a certain temperature and they have to move. The motility has to be just right. So there's all these different things within the male's reproductive system that help keep them in tip-top shape. So as far as the actual fluid that's within like ejaculation, so it's an alkaline fluid which helps with the sperm motility. It helps to nourish the sperm and protect the sperm when they actually do get to the vagina and the acidic environment of the vagina. So there's just a cross section, and then just another look at the testes. Okay, I've got a few practice questions here to kind of bring it all together. So, what event occurs during the proliferative phase of the menstrual cycle? What do you guys think? Anybody? You can cheat. You can go back and look.
Is it C?
Anybody else have any guesses? So
I'm seeing B
proliferative
in the chat.
is when the endometrium starts to thicken. Yeah. So I kind of broke down here and I made a little way, like a mnemonic to remember this. So my period sucks is your menstrual, proliferative, secretory, and then ischemic would be the I if you go into ischemic phase. So your proliferative phase is after your menstrual phase. So you start bleeding and then the endometrium starts to thicken back up again. So that's your proliferative phase. Ovulation is its own thing. Some textbooks have like an ovulation phase. Yours doesn't. So it's just ovulation. That's not part of like one of the phases. And then your progesterone secretion peaks, which was the D, was answer D. That would be your secretory phase. So that's when the progesterone that's secreted from the corpus luteum is high, is in your secretory phase. Okay, let's look at this one here. So which phases of the endometrial or uterine cycle correlate with the follicular phase of the ovarian cycle? So follicular phase is the first phase of the ovarian cycle. So what?
A and D. A and D.
Okay.
Is it the
A and D. Good job. So that's your menstrual phase and your proliferative phase. That's what's happening at the same time that you're in your follicular phase of the ovarian cycle. So you're having your menstrual bleeding, and then you're starting to thicken that lining back up in your proliferative phase. Okay. How does cervical mucus change during the menstrual cycle? Why does this happen? And how can we educate our patients to use this information? So how would you guys answer this one?
It gets thick to prevent pregnancy, and then as you ovulate, it thins, so the sperm has a smoother ride.
Yay! Love it. Perfect. Beautiful. All right, and there's our cuterus, our cutie uterus. Okay, good job, guys. Okay, I know that that is a lot of information. So I tried to give you some practice questions so that your brain can start making those connections and you can start kind of critically thinking like, okay, while this is happening in the ovaries, this is happening in the uterus. That way you can kind of put that together to create like the whole picture of what's happening in the menstrual cycle. So I would take that as like a hint that that might be something that you would get questions on because I'm really trying to help you guys really make those connections, if you get what I mean. Okay. All right. Do you guys need a short little break before we go to the next one? Okay, just like a little mental break. Let's start back up at 10:40 and we'll go into chapter 4. Okay, let's start with chapter 4. Now that we have a general understanding of anatomy and the menstrual cycle, we'll talk about a few things that can go wrong with all of that. Okay, all right. So now our little cuterus is back, but she needs help now. Let's see what's going on. We are going to learn a bunch of new vocabulary, I feel like, in this chapter. So any like new word like amenorrhea, I would write that down in your notes and make a little flashcard. And that way it's something that you can practice with this new language. And so when you get to the test and I use these fancy words, you know what I'm referring to. So amenorrhea is the absence of menstruation or the absence of a period. So this usually indicates an issue with either the hypothalamus, the anterior pituitary, the ovaries, or the uterus, or a combination of one of those 4 things, since they all kind of work together to make that menstrual cycle happen each month. So amenorrhea is split into 2 different types, primary or secondary. Primary would be the absence of menarche. So menarche, another fancy word, means your first period. So the absence of the first period by age 15 without secondary sex characteristics. So that person doesn't have any secondary sex characteristics. They're 15 and they haven't had a period. Or if they are 16, but they do have secondary sex characteristics, that all falls into primary amenorrhea. And then secondary would be the absence of 3 menstrual cycles or 6 months in women who were previously menstruating. So basically, what I think of with secondary amenorrhea, probably the most common thing is like PCOS. So women who have polycystic ovarian syndrome often will skip periods or have really like crazy cycles all over the place. And so they have this like secondary amenorrhea. There are many different causes. I think I even have another slide. Yeah. So for primary amenorrhea, here are just some of the causes. And you guys don't have to memorize this. This is just more like for your information. So it could be some type of congenital anomaly within their reproductive system. They could have a genetic disorder like Turner syndrome. They could have an absence of a vagina or an absence of a uterus. Some women have 2 uteruses. Some crazy things happen. They could have a lot of stress in their life, or maybe they are exercising excessively and that is causing them to miss periods. Certain medications can cause that. Polycystic ovarian syndrome that I mentioned. Maybe they have an imperforate hymen, so that hymen completely seals off the vaginal opening. Maybe they have some kind of chronic condition. Maybe they're pregnant. So lots of different causes for primary amenorrhea. And then same thing for this secondary amenorrhea. Once again, maybe they're pregnant. Maybe they have some type of adhesions going on. Maybe they have a tumor, PCOS. So lots of different things. Like I said, you don't have to memorize this. This is just more for your information. Okay, so let's talk about some menstrual disorders. So here and there, you're going to see this AUB, which can stand for atypical or abnormal uterine bleeding. So this could be heavy or prolonged bleedings. The fancy word for that is menorrhagia. So that just means you have heavy bleeding, lots of bleeding outside of that normal. You could have metrorrhagia, which is normal menstrual bleeding, but at irregular intervals between menstrual periods. So you have a period, and then you have bleeding a couple weeks later, and then you have another period, and then you have spotting. So you just have all of this bleeding in between your cycles. So in between metrorrhagia. And then similar, so breakthrough bleeding is just metrorrhagia when you're on a hormonal contraception. So like if you're on like birth control pills, they'll call it breakthrough bleeding. It's just another way of saying metrorrhagia. So this breakthrough bleeding in between your cycles. Okay, and then another word, dysmenorrhea. So dys is pain. So dysmenorrhea is painful or difficult menses. That can also be primary or secondary, like I mentioned. So primary just means that we don't really know why this person has painful periods. We can't make a connection with any kind of disease process or any diagnosis. They just have painful periods. Secondary would be that we can make a connection. So maybe they have endometriosis. Maybe they have uterine fibroids, and that's what's causing their periods to be painful or dysmenorrhea. So how this presents is it usually begins about 6 months to 2 years after their first period, after that menarche. It can be severe intermittent cramping. It could be constant pain. With that can come nausea, diarrhea, fatigue, headaches. And how we manage this is typically with NSAIDs, so like ibuprofen. We can also do Tylenol or acetaminophen. And then birth control pills. So sometimes people just need their hormones to be more consistent, and that helps their menstrual cycles to be more consistent. They don't have these huge fluctuations in their hormones. And then with that, it helps to improve their discomfort and their bleeding. And then there's something called PMS, or premenstrual syndrome. So these are physiologic and emotional symptoms that can occur during the second half or the luteal phase of the menstrual cycle. So physical symptoms could be like breast tenderness, bloating, headaches, swelling, behavioral symptoms, just kind of like emotional outbursts, or feeling depressed or anxious, angry. Not everybody gets this, and it doesn't happen every cycle, but for other people, this can be really debilitating, and we don't know what causes this. How we manage PMS, sometimes it could be a diet change, exercise program, trying to manage whatever stress is in their life, improving their sleep and rest, NSAIDs like ibuprofen for pain control, maybe birth control pills, once again, to try to keep those hormone levels more consistent, or maybe some SSRIs. A more extreme form of PMS would be PMDD, so premenstrual dysphoric disorder. So it's all of those symptoms, but really elevated. This really is debilitating month after month after month for these patients. So it just kind of depends, the treatment depends on what the symptoms are that they're having. So we're going to try to treat, those symptoms. So do they need SSRIs? Do they need diuretics? Do they need NSAIDs? Do they need a combination of all of those things? Now, of course, when we become pregnant or when we're menopausal, that's going to eliminate PMS and PMDD, but those things are not always options for everybody, right? So we have to manage them with other things. Okay, another disorder that some of you may be familiar with, maybe personally, or you know someone, is endometriosis. So this is a very painful reproductive disorder where the endometrial tissue, so that endometrial lining, that inner lining of the uterus, that particular tissue starts to grow in other places outside of the uterus. Typically, it's still in the pelvic cavity, but it could be on the bladder, on the bowels, on the fallopian tubes, on the ovaries. I mean, it's been everywhere all over the body, but those are probably the most common places. So where this tissue implants or goes, we call those implants, or we call them lesions. So they create their own blood supply, and because it's the same tissue, it also responds to those hormonal changes of the menstrual cycle. So it also bleeds, and it becomes very uncomfortable, crampy, and painful. Some people have really, really terrible endometriosis where they just have lesions all over their pelvis, and other people may have, small lesions here and there and may not even realize it. How this presents is usually heavy, painful, cyclical. These symptoms are cyclical. So each month, all of a sudden now they're in pain again, they're having heavy bleeding again, they're having pelvic pain again. And then this word here, dyspareunia, is painful intercourse. So a lot of times these patients will experience painful intercourse or dyspareunia. So these are just kind of all the places where that endometrial tissue can grow. So like I said, pretty much anywhere in the pelvic cavity. So the treatment depends on the severity of symptoms and also kind of what that woman's goals are. So is she trying to start a family? Is she done with having children? Like, what are her goals? And that helps us figure out what type of treatment to use. So if she's wanting to have a baby, we don't want to put her on birth control or take her uterus or something like that, So if it's mild, if the endometriosis is mild, a lot of times they'll do NSAIDs like ibuprofen, and then if she's not wanting to conceive, we'll do oral contraceptives. If it's more severe and she's not wanting to conceive, then we will give her medications to kind of put her in like an artificial menopausal state. So it'll really change those hormone levels. She'll now experience perimenopausal symptoms, unfortunately, but she won't have the cyclical pain. So it really just depends on how severe this is. And the only way that we can truly, I don't know if I have this on here, sorry, I wanted to see what all I had on here. The only way that we can truly diagnose endometriosis is with a laparoscopic procedure, which most people do not want that. But if it is something that they choose to do, we go in laparoscopically with a camera. If we identify lesions, then they actually get the diagnosis of endometriosis. Sometimes we can remove those lesions and that can help. But other times it's just kind of everywhere. There's too much scarring. But a lot of times this diagnosis is just based on symptoms, and that way they don't actually have to have the procedure, but we can kind of treat it as endometriosis by doing NSAIDs, by doing oral contraceptive pills, things like that. So once again, NSAIDs, birth control pills, usually it's like a low dose oral contraceptives, which is OCs. So they'll do, you'll take them continuously. So instead of like having your period each month, you'll just go right into a new pack of pills, and that helps to keep the hormone levels stable so that you're not having those fluctuations. Also something like Depo, which is the injectable birth control, or an IUD like Mirena. We can also do like the false menopause, or these like SERMs, which are selective estrogen receptor modulators. So it really lowers that estrogen level, kind of puts them into this false menopausal state, but then they're going to have menopause type symptoms like hot flashes and things like that. And then there's just some other complementary therapies that we can use. All right, we'll talk a little bit about family planning and then some birth control. So of course, if we are, if we have all the control in the world and we can plan for pregnancies, it's going to give us control over the number of children that we have and like when they're born and when we're done reproducing. Things don't always work out quite like that, but we'll talk a little bit more about like preconception planning and things like that. But I think right now we're going to focus more on preventing pregnancy and kind of what those different options are. And you guys will talk a little bit more in lab about this as well. Oh, it does go over a little bit of planning here. Let me see what we got. Okay, just 2 slides on planning pregnancy. So, preconception care. So this would be something that some patients choose to make appointments like with their OBGYN before becoming pregnant because they want to kind of set themselves up for success, or maybe they know that a certain genetic disorder runs in their family, or maybe they're on some high-risk medications and they want to transition to something a little bit safer before they get pregnant. So preconception counseling is fantastic if all the stars align and that person's able to have that happen. So at least 3 months before, we like our patients to have a nice healthy diet, be active, start a folic acid supplement. So folic acid is something that we know helps to prevent neural tube defects. Neural tube defects are things like spina bifida, so an abnormal formation of the spinal column. By taking folic acid, it can decrease your chances of developing one of those issues by like 70%. So taking folic acid ahead of time really helps with that. And we'll talk a little bit more about fetal development and why that's so important in those first couple weeks, because you're already developing that neural tube even at 6 weeks of pregnancy, which is just crazy. We also want to counsel on avoiding STI exposures, certain harmful chemicals and toxic substances, making sure that that woman is up to date on her vaccinations. Most vaccinations you can't receive once you are pregnant, so it's good to have those on board ahead of time. If you can try to manage and reduce your stress ahead of time, stop smoking, stop using drugs or certain medications, prescription medications. Reduce your alcohol intake, either completely or just really drink here and there, not once you're pregnant, but stop any kind of intimate partner violence or end that relationship. Easier said than done. Manage any pre-existing health conditions, learn about your family health history, get regular checkups. So like I said, in a perfect world, yes, these would be wonderful things if all of our patients could have this preconception care. But, we know that pregnancies happen, surprise pregnancies happen every single day. Okay, so let's talk about preventing pregnancy now. So we'll talk about some of the different methods, and then in lab, I believe we cover a little bit more of this, and you can actually see some of these. So natural methods would be things that don't require any kind of prescription medication. This is things that the patient would do on her own. So the first would be abstinence. So if you're not having sex, then you're not going to have a pregnancy. Another common one is coitus interruptus. So that would be the pull-out method. That's a fancy way of saying pulling out. So coitus interruptus. In your book, I'm pretty sure there's a chart. There's several pages, you turn it sideways and you can see how successful these different methods are, the failure rate and things like that. So I encourage you to go look at that just because it's interesting, I think, to see how good is it if I'm just using the pull-out method or if I'm just using lactational amenorrhea. So lactational amenorrhea is where you're breastfeeding exclusively, which usually is pretty good for the first few months. If you are breastfeeding no formula whatsoever and you're breastfeeding every couple of hours, that does suppress ovulation. But once that baby starts to sleep through the night, or once you start to introduce solids or any kind of formula, that's going to mess everything up. But that's what lactational amenorrhea is. And then those fertility awareness methods. So I had mentioned some women will check their cervical mucus. You can check your temperature, you can follow a calendar or follow your symptoms. So some women really do have that textbook 28 days. And so it is very easy for them to kind of know when they are ovulating. But even somebody with a perfect cycle, things can disrupt that. Medications can disrupt that. Stress, exercise. So it's just one of those things that it's not 100%. But there's also ovulation predictor kits that they can purchase. So all kinds of different things. So these natural methods, about less than 1% use these methods. It does take a really strong commitment from both partners. You do need very regular periods to be successful with these, or to be more successful. So the science behind it is the ova, or the ovum, or the egg, is released around day 14. So that's when you ovulate, is around day 14 for somebody that has a perfect 28-day cycle. And that ovum lives for about 24 hours. And then sperm can live up to 5 days in the female reproductive tract. So you kind of have this window of opportunity. So you don't know exactly when you're going to ovulate. You don't know exactly when the sperm is going to meet that egg. So you would want to have intercourse within your fertile window, or not have intercourse during that time. So cervical mucus method. So you're looking to see for that spin barkeet to kind of guide, okay, do we want to have intercourse during this time if we're trying to conceive, or do we want to avoid intercourse if we do not want to conceive? Basal body temp method. So this would be that the woman takes her temperature every single morning before getting out of bed. So once she gets out of bed, that's going to alter her temperature. So it's before getting out of bed, she would take her temperature and keeps that information on a chart. And when she sees that slight rise in temperature, that would let her know that she is ovulating. But a lot of things can throw this off. If you get up in the middle of the night to pee, or maybe you have other children that get you up in the middle of the night, that's going to alter your temperature. So it's kind of a risky one to use. Symptothermal, so that's kind of combining a lot of these different methods. So you use your temperature, you use your cervical mucus, you base it on sensations in your body. So Mittelschmerz, that's a pain that some women can experience during ovulation. It's a one-sided pain during ovulation. It's called Mittelschmerz. So some women are able to feel that. Standard days method. So if you're a 28-day cycle person, you kind of know where you're at in your menstrual cycle and when you would ovulate. There's also these beads that some women will wear like on their wrist. And so there's a little rubber ring that they will move for each day. And so that they know like, okay, now that I'm on these white beads, I could become pregnant. I want to avoid intercourse. And then withdrawal or coitus interruptus or pull-out method can definitely still get pregnant with this method because it only takes a few drops of ejaculate it has a huge concentration of sperm. So you can definitely still get pregnant that way. And then lactational amenorrhea, which I mentioned, is fairly effective for about up to 6 months if you're breastfeeding every few hours exclusively. Okay, and then barrier methods. So things like spermicide, condoms, diaphragms, talk about some of those. So diaphragms aren't used as frequently anymore because we do have so many other like hormonal options. But a diaphragm is something that does require you to go to your GYN. You have to be fitted and then you get a prescription. So this is just kind of some different diaphragms and what they can look like. You do have to use spermicide when placing this. There's no protection against STIs. So that's an important thing to teach your patient about. You can put the diaphragm in up to 2 hours prior to intercourse, but after intercourse, you have to leave it in for at least 6 hours. That gives that spermicide a chance to do its job and kill any of that sperm. They do have to be replaced about every 1 to 2 years, depending on the brand, and they have to be refitted after any pregnancy or any 10-pound weight fluctuation, which I feel like a 10-pound weight fluctuation, that's a pretty easy thing to do as a woman. So the fitting can definitely be off. And also the patient would need to be able to demonstrate in the office that she can insert it and remove it and place it appropriately. So once she's able to pick it up from the pharmacy, she would bring it into the office to demonstrate those things. Cervical cap is kind of similar to the diaphragm. It's just a little bit smaller, fits over the cervix. It's also fitted by a practitioner, comes in 3 sizes. You can put it in 36 hours prior to intercourse, but you do have to also leave that in 6 hours after intercourse. It's replaced annually. You have to use spermicide with that as well. Contraindications, kind of the same thing with the diaphragms, like if they have a rubber or latex allergy, depending on what it's made out of. Somebody who has like frequent UTIs or a lot of exposure to like STIs or any kind of infections, these are really not good options for them. And there's also a sponge. So this sponge is already impregnated with spermicide. So the spermicide's already in this. So you get it wet and you squeeze it. It gets all like soapy and foamy. And then you place it inside over the cervix. It does have a little loop here to be able to remove it. It can be used for multiple acts of intercourse. It can be inserted 24 hours prior to intercourse, and it needs to be left in for at least 6 hours. But you don't want to leave it in longer than 30 hours because you can get toxic shock syndrome. So, there's pros and cons to these. No hormones. It's something the woman has complete control over, but there's also cons like having to worry about having it placed and ready to go and then leaving it in and cleaning it and storing it. So just depends on what that patient's looking for. Okay, let's talk about some hormonal methods. So we'll talk about birth control pills, the injection, the implant, patch, and the ring. So the first thing, and probably one of the most common, is combined oral contraceptive pills, or COCs. So these pills contain both estrogen and progesterone. And depending on the prescription and like the brand, there's different doses of those hormones. They can be monophasic or triphasic. So it just depends. Your provider is the one who kind of decides what would work best for you, depending on what your issues are, like your menstrual cycle issues. So how this works, or how these pills are successful is they suppress ovulation and they inhibit implantation. So they make that cervical mucus hostile. They don't allow the endometrium to thicken up, so it's not great for implantation because it's too thin. And then it prevents the whole ovulation process. So it's kind of taken things on from different angles to prevent pregnancy. You do take 1 pill per day around the same time each day. Typical dosing is 28-day dosing with the last 7 days as like placebo or sugar pills. That also just depends on the pill. Some of them only have 4 sugar pills, some of them have 5 sugar pills. So it just depends on the prescription. But once you take those placebo or sugar pills, those pills don't have any hormones. So then that signals to your body, all the hormones drop, and then you have a withdrawal bleed or a period, and then you start your new pack when you're due to start your new pack. These also can be taken continuously, so you can take them 84 days on and then have 7 days off. So I talked about like for endometriosis, so that you're not having all those hormonal fluctuations. You just skip your placebo pills and go straight into a new pack of pills. But usually about every 3 months, they want you to have a withdrawal bleed or a period, and then you kind of go back on the pills for 3 months again. So it just helps to keep your uterine lining nice and thin and prevent those hormone fluctuations. As far as like a pap smear, you don't need an annual pap. We used to back in the day, everybody got a pap smear every single year, but we've gotten away from doing that. You still need a pelvic exam every year, but the actual pap test is either every 3 or every 5 years. So you guys don't need to know all that. If you work in an OB/GYN, you're going to do a lot of education about pap smears. Okay, so some advantages to these combined oral contraceptive pills. So it does help regulate and shorten the menstrual cycle. It does help decrease cramping and bleeding. Also, caveat to this, not everybody responds to these the same. So if you're listening to me right now and you're like, well, they didn't help me, that is very true. They do not help everyone, but it's kind of a trial and error. They're hormones, so everyone kind of responds differently to hormones. But for the most part, they do help these things. So they do help reduce the amount of bleeding, so then they can reduce anemia. They can improve those PMS or PMDD symptoms. They can reduce ovarian, endometrial, and colorectal cancer. They can decrease benign breast disease, improve acne, improve headaches, minimize those perimenopausal symptoms, decrease rheumatoid arthritis, and protect against bone density loss. Okay, so some disadvantages. There's no protection against STIs. You are at a slightly increased risk for blood clots, and they are associated with an increased risk of heart attack, stroke, and hypertension. So there are certain patients that cannot have these, and we'll talk about that. They may increase depression. They may increase risk of cervical cancer, which I've never really heard that before, but I think that was just in your book. That's interesting. You must take them daily, and then sometimes they can be too expensive depending on if you're paying out of pocket or your insurance coverage. So things that we educate our patients on who are given a prescription of combined oral contraceptives is this acronym ACE. So the A stands for if they're having any abnormal abdominal pain, which that's kind of a vague symptom. So, but severe abdominal pain outside of the normal, like cramping, could indicate liver or gallbladder problems. C, of course, if they're having chest pain or shortness of breath, that could indicate a clot, like a pulmonary embolism. H for headaches, which could indicate hypertension or impending stroke. So if all of a sudden, like they weren't having any headaches and now you put them on a combined oral contraceptive and they're having headaches every single day, that's a warning sign. E is for eye problems, which could also indicate hypertension. And then S, like severe leg pain if they have like a clot in their leg. Okay, so there are some contraindications. So certain patients cannot take combined oral contraceptive pills, and it's because of the estrogen. The estrogen is the one that we have to worry about, not the progesterone. So if your patient has a history already that they've had blood clots in the past, DVTs, PE, stroke, they are not a good candidate for an estrogen-containing birth control. If they have certain types of heart or liver disease or other certain cancers, They can't have estrogen. If it is someone who is 35 years or older and they smoke, they are not a good candidate for estrogen. They are already at risk for blood clots. We don't want to increase that risk. If they have uncontrolled hypertension, if they have migraines with aura. So most of the times, if they just have migraines, they can still take this type of pill, but if they have a migraine with an aura is like something you get before a migraine comes on. So it could be a visual disturbance, a taste, a sensation in the body, and then that's your signal that a migraine is coming. Those are more risky for blood clots and stroke. So we would not want to give that person estrogen. And then if they're breastfeeding, so combined oral contraceptive pills are not dangerous for breastfeeding mothers, but it can decrease their milk supply. So that's why we don't give them for breastfeeding mothers. So keep in mind these contraindications. Okay. There is another type of birth control called POPs, or progestin-only pills. These pills are just progesterone or progestin. They do not have estrogen. So all of those people I just talked about, all those contraindications, they could take this pill. It's also called the mini pill. It's about 99% effective if taken perfectly, which most people don't. How it works is it prevents ovulation about 50%. It thins the uterine lining, it thickens the cervical mucus, and it prevents egg transport. So this is a good option for your smokers that are over 35, your breastfeeding moms, if somebody's had a clot, if they have some type of cardiac disorder, this is an option for them. So these particular pills, they're taken once per day as well, but they have to be taken at the same time every single day. Whereas the combined oral contraceptives, you have a little bit of wiggle room. Like if you miss it by a couple hours, you're okay. These, you got to be really careful. It really should be at the same time every single day. And then each one of these pills has the exact same amount of hormone. So you don't have the sugar pills or the placebo pills. So a lot of times this will change that person's bleeding. Some people, it will increase their bleeding, but for a lot of people, it actually decreases their bleeding to the point that they don't have a period anymore, or they have such light periods just because their hormone levels are the same every single day. So once again, we're all different. We all respond to hormones differently. So it's kind of a trial and error to see how you're going to respond to it. And I always tell my patients that it takes a few months to figure out, like to kind of regulate. So with pills, it takes about 3 months to see how your body's going to do on it. Whereas like an IUD, it takes about 6 months. So there's a little video if you want to watch. It compares and contrasts the different types of birth control pills as far as estrogen and progesterone and how they affect the body. Some other hormonal options, so Depo-Provera, which is the injectable birth control. This is a really common one. This is a progestin-only method, so this is a good option for those people with contraindications to the estrogen. Just has progestin. It's 150 milligrams. It's an IM injection that's given every 12 weeks. It is very effective as long as you are doing it correctly and getting it, every 12 weeks. Some common side effects are it can, for some women, it can cause bleeding, irregularities like breakthrough bleeding or maybe heavier bleeding. Weight gain is a big one that I saw. It does cause some weight gain. It can make acne worse, depression, and it does have some bone loss. If you're on it, I think it's 10 years or greater, it can cause some bone loss. It is reversible, but they just don't want you to be on this for long term. So that's Depo. And then the birth control patch, there's different makers of the patch, so I didn't put like a brand name on here, but it's a 2-inch adhesive patch. This is a combined method, so it has both estrogen and progesterone. You put one new patch on each week, and then once you get to that 4th week, you take the patch off for a week. That's when you would have your period. At the end of that week, you would place your new patch. It does have a little bit of weight gain as well. As side effects, it can also have some like breakthrough bleeding, kind of the same things. And then the BMI of the person, so if they have a higher BMI, it can decrease the effectiveness. So I can't remember exactly what the weight limits are, but it's kind of low, honestly. So that's just something to be aware of. So these are the different places that you can put the birth control patch. And of course, you would want to rotate your site and make sure you're not having any kind of allergic reaction to wherever you put it. Another option is the vaginal ring. So probably the most common maker of this is NuvaRing. This does contain both estrogen and progesterone. It's a flexible ring that you insert vaginally. It stays in for 3 weeks. Take it out for a week, have a period, and at the end of that week, you would put a new ring in. So kind of similar. It can make bleeding more, or it can improve bleeding. Cramping, kind of the same side effects. It just really depends on the person, but. Okay, so some other options, IUDs. So an intrauterine device or an IUD can either be with hormones or without. So we'll talk about the copper IUD, as well as like a Mirena, or there's other companies, Skyla, Kylena. There's a bunch of different people now that make them, but we'll talk about the implant or the Nexplanon, sterilization. So like a woman can choose to get her tubes cut and tied and burned, or she could get a hysterectomy, and then men can get a vasectomy, and then emergency contraception. So things like Plan B. All right, so a little bit about IUDs and implants. So an IUD or an implant, like the Nexplanon, those are called LARCs. LARC stands for long-acting reversible contraception. So some providers will just say LARCs. So these are things that can be placed in the body for years and years and years, but can also be removed at any time and fertility resumes. So Paragard is the copper IUD, which is this picture right here. So no hormones, it's just the copper. Copper is a spermicidal, so it kills sperm. It causes an inflammatory response and makes the uterus hostile to implantation. So it kind of disrupts that uterine lining so that nothing can implant. No hormones, good for 10 years. I actually think it was just approved for 12 years. So I need to update my slide. So that's great. You can put it in there, and as long as it stays where it's supposed to, you're good to go. Now, of course, there are caveats to all of these, and I'm sure some of you have stories about how you had an IUD and it got out of place, or so-and-so got pregnant. Yes, they are not 100%, but for the most part, they are very successful. Hormonal options would be a Mirena, a Kylena. There's something called a Jadis, so different brand of these now, but I would say Mirena is probably the most common, and it's now approved up to 8 years for birth control. Sorry, lose my train of thought. The hormone is progesterone, so no estrogen. It causes the endometrium to be thin, and then it thickens that cervical mucus. And it can help lessen menstrual flow, or decrease your period, decrease the number of days, as well as like the actual bleeding itself. And we want to just be cautious with placing any kind of IUD with someone who has frequent infections. A lot of times they will do STI screening prior to placement. We don't want to place this when somebody already has, chlamydia or something like that, and then we're introducing that bacteria even more up into the reproductive system.
We're walking through the zoo. We're walking through the zoo.
Somebody needs to put themselves on mute.
Corey, can you mute yourself?
Okay, and then a little bit about the implant or Nexplanon. So this is a little 4-centimeter like rod that can be inserted in the office underneath like the underside of the arm. They'll numb that area, and then there's like a little transducer that they will place it, goes right under the skin. It's good for 3 years, but I want to say they actually made it to 5 years now. They've just recently updated all these birth controls, so I need to double check, but it's definitely good for at least 3 years. It inhibits ovulation. Oh, did somebody have a question?
Oh, you just got food delivered to you.
Oh, Corey, I'm going to mute you. Okay. Sorry,
Hey, I
guys.
got a quick question for you, Miss Siska.
Oh, yeah, go ahead.
So my internet keeps like cutting out. I'm not sure why, but it's messing up like my recording. Are
Oh,
we gonna like have access to the like lecture?
well, I'm recording it and I'll post it into Brightspace, so hopefully it'll be all connected on my
Cool.
end.
Sounds
Okay.
good. Appreciate you.
Yeah, no problem. Okay. Let's see. So Nexplanon, placed under the arm. It's about 99% effective. It's progesterone only, so no estrogen. And it's reversible. So it lasts for, I think, up to 5 years, but you can get it removed at any point, just like with the IUDs. So they last up to 12 years if it's the copper, but it can be removed at any point. Okay, and then a little bit about emergency contraception. So this would be when you have unprotected intercourse and you are not wanting to conceive and you're worried that you were within that fertile window. We have some options for emergency contraception. So this does not cause abortion. This prevents the embryo from ever like forming. So it's used within 72 to 120 hours after unprotected intercourse. The earlier you use it, the more successful it can be. It has a 90% reduction in the risk of pregnancy. Common ones would be Plan B, which can be purchased over the counter. And then there's also this UPA that your provider can prescribe. And a lot of insurance companies have started covering this, which is great because Plan B is like $50 out of pocket. So if your insurance covers it, that's fantastic. So I always tell my patients to try with insurance first. And I also think that the one that's prescribed has a little bit higher weight. So if your patient is a higher BMI, I think that this is a better option than Plan B. I can't quite remember the weights, but and then a copper IUD can also be used as emergency contraceptive if it's inserted within 5 days from that unprotected intercourse. The issue with that is you have to make sure you're established with a GYN or you can get an appointment within that time. And then you have to get insurance approval for that IUD because you don't want to pay out of pocket. It's over $1,000 for an IUD. So typically that process takes time to like get in for an appointment to get insurance approval. So if you are one of the lucky people that can get all of that, then it is a great method. But and then another option would be a Mirena IUD as well. But kind of the same issues with that. And then you can also do combined oral contraceptive pills that are dosed in a certain way. So the provider would write them so that you take multiple pills at once. So depending on the emergency contraceptives, if we're talking like Plan B, you don't need a prescription. There's no age restriction. Anybody can buy that. If you're doing the oral pills, they can cause nausea and vomiting, so it can be sometimes difficult to keep those down. So sometimes the provider will also prescribe like Zofran or something like that. They do not cause an abortion. That's a really good teaching tool. They just prevent the creation of an embryo and block that implantation. And they don't take the place of birth control. So definitely if you have a patient who's using emergency contraceptive, you want to talk to them about, okay, long-term, what is our plan here? How can we prevent this from happening again? And then because they, like if you take Plan B or the prescription UPA, it really jacks up your menstrual cycles. So that's an important thing to tell them too, like, hey, you may have 2 periods this next month, or you may have heavier than normal bleeding, or your period's not going to come when you expected it to. So anything like that, or if their period does not come, you need to make sure that they take a pregnancy test because it's not 100% and they could still be pregnant or become pregnant. Okay, so we'll talk a little bit about abortion, or as we refer to it, abortion as miscarriage. So there's different types of abortion, different types of miscarriage. So I just want to make sure you guys kind of knew all that terminology. So a spontaneous abortion is a miscarriage. So it's a loss of a pregnancy. An induced or therapeutic abortion is a purposeful termination of a pregnancy. So that could be something that the mother just chooses to end the pregnancy, or it could be that the life of the mother is at risk, or maybe there is some type of genetic component with the baby and it needs to be terminated, something like that. So there's always more information there, but that's an induced or therapeutic abortion. And how we do this is either a medical technique or a surgical technique. So some medications that we can use would be methotrexate. So that's a common one for women who have an ectopic pregnancy, which we'll talk more about in another chapter. But methotrexate is a medication that's typically used for cancer cells. It destroys fast growing cells, which is what a pregnancy is as well. So it helps to dissolve that pregnancy. So like with an ectopic pregnancy, we have a pregnancy that is growing typically in the fallopian tube. If we allow it to continue to grow, eventually that fallopian tube will rupture and that woman will experience mass amounts of bleeding and could die. And so that prevents this from happening. Another medication would be mifepristone with misoprostol. So these are medications that help to block progesterone and cause uterine cramping. So it will terminate the pregnancy and allow the body to pass the pregnancy. And then surgical techniques, we can do a D&C or a D&E. So they dilate the cervix and then they can kind of clean out the uterine lining or suction out the uterine lining. All right, and then just a little bit about infertility. Your book doesn't go into like a ton of like infertility workup. If this is an area that you would like to pursue, like in a fertility clinic, you'll learn way more, but this is just kind of the basic stuff. But so infertility is the inability to conceive after a year of unprotected intercourse, and that's usually for couples who have no other risk factors. So they're under the age of 35 and they don't have any known risk factors, and they've tried for an entire year of timed intercourse and they have not achieved a pregnancy. That is considered infertility. So as far as risk factors, there could be male factors or female factors or both. There could be behavioral factors, occupational, environmental. It just depends. So some specifics to women could be her age, if she has that PCOS or polycystic ovarian syndrome, certain medical conditions, maybe something with her hormones, an issue with gamete transport. Gamete is your sex chromosome, your egg, or implantation interference. So something with the actual implantation into the uterus. Men, it could have something to do with like their sperm, the way that they move, or their amount of sperm, so like a sperm count. I think here, I talk about that. So one of the first things we do for a workup for infertility, a lot of times they'll do labs on mom and dad, but they'll do a semen analysis. So they will have the male ejaculate into like a specimen cup, and then they will look under the microscope and they will count the amount of sperm. They will look at the way that the sperm move and just overall like what they look like. So their morphology. Do they have normal head, normal tail, or do they have like double tails? Are they moving in an odd way? Do they have less than the normal amount? So it's something that we can rule out very quickly with a semen analysis, and it's not an invasive procedure. So that's one of the first things that they will look at. For female, obviously we'll do a history and physical, may have her do some like home ovulation predictor kits, or have her come in for labs to see if we can figure out does she ovulate or not. There's certain oral medications that we can give like Clomid or Femara, which can help her to ovulate. There's a procedure called an HSG, where they will inject dye up into the fallopian tubes to make sure that they are patent. Some people have scarring in their fallopian tubes, and so that's preventing that egg from getting through to the fallopian tube and like making that proper descent into the pelvis or into the uterus. And then maybe a laparoscopic procedure to just look for any other causes, maybe endometriosis with a lot of scar tissue or something like that is going on. So interventions are just going to depend on if we can figure out the cause. A lot of times, this type of workup is not done at your normal OBGYN. It's something done at a reproductive endocrinologist, an REI physician. But some things, depending on like your regular GYN can do like an HSG and can do Clomid and Femara, things like that. But things like IVF or IUI, that's going to be a reproductive endocrinologist. But things that we can also suggest would be lifestyle changes like losing weight or to stop smoking. A lot of the other interventions insurance may not cover, so that's a huge issue. These are very expensive procedures, and obviously it's an emotional roller coaster. It's a really difficult thing that we help support our patients through if this is like an area of nursing you go into.
This might be a stupid question, but
No, you're
with
fine.
you mentioning like Clomid, will we have to know the risk of like multiples with the pregnancies that can come from like Clomid or anything like that? Okay.
Nope. I'm not going to have you guys go into infertility stuff. That's like a way, we're just going to cover the basics, but no. And you don't, I mean, honestly, you don't even know you don't need to know what Clomid is. I won't put a question on there like, what is Clomid used for? Like, that's just, this is more like information. So you have a little bit of background about infertility and some treatment options.
Okay,
but
thank you.
definitely not the focus. Yeah, you're welcome. Okay, so, and then obviously with infertility, there's a huge psychological aspect. So like I said, this is just something that if you do work in like an OBGYN clinic, we do have patients that we help kind of through this process. And it's very emotional, really difficult thing to go through. Okay, and then menopause, so the opposite end of the spectrum here. So I already mentioned that to be menopausal, you've got an entire year without a period, but that perimenopausal, so those years leading up to menopause, can be anywhere from a couple years up to like 10 years. So it takes a while, but during that time, menstrual cycles are going to become irregular. They can be heavy. You can miss some cycles. Your estrogen levels are going to fall by 90%, which is what causes a lot of those symptoms like the hot flashes, the irritability, difficulty sleeping, things like that. And then you can have you have menstrual cycles, but you're not ovulating. So anovulatory cycles just mean that you're having menstrual cycles, but you're not ovulating. So that's kind of what starts to happen as we age. So age 35 and older, we have more of these irregular cycles that we may or may not ovulate. And that's why our fertility starts to decrease. You can still get pregnant though. So a little bit more about some menopausal changes. So I mentioned like hot flashes, disturbed sleep, mood and memory problems. We can have lower levels of that good cholesterol, increased risk of cardiovascular disease. Our bone density starts to decrease. We have osteoporosis, breast changed. Within our like GU system, we have more like vaginal dryness, stress incontinence, some GI disturbances. This just like your overall skin becomes dry and more sensitive. We accumulate more abdominal fat. So lots of really fun things to look forward to, ladies. We do have medications to help control some of these symptoms. So it just depends on how severe they are. You know, is it something that's affecting their daily life? We have to be careful with hormone replacement therapy. We like to not use it at all, but if we are going to use it, we use low doses to just help lessen those symptoms. May not completely get rid of them, but make them more manageable. Because we do know that hormone replacement therapy does have an increased risk of breast and uterine cancer. So we just want to use it at the lowest possible dose and only when necessary. Okay, so some practice questions here. Which of the following patients would be a good candidate for a combined oral contraceptive pill? So this is one that has estrogen and progesterone. What do you guys think?
A.
B.
C.
Is it C?
Is it C?
Okay, let's see. Hey, yep. So we wouldn't want to use it for somebody who wants protection against STIs because that's not going to do it. We wouldn't want to use it for someone who doesn't want hormones because it has hormones. And we don't want to use it for somebody who's 42 and smokes about half pack of cigarettes per day. So our best option here is this 24-year-old who wants a reliable form of birth control but doesn't want anything implanted in her body. Okay, which birth control method provides protection against STIs? Select all that apply.
That's male and female condoms.
Yep, that's it. That's all you get. All right, and there's my little speculum. There has to be a better way. Sorry, I'm a nerd. Okay, let's keep going here. We are gonna talk about some STIs. Like I said, back to health class today. And you guys will probably do a little bit of this in lab as well. I'm pretty sure that's one of the things we cover in lab. Is that right, Nicole? Do you do STIs? I haven't looked over the lab stuff yet. Oh, maybe Nicole's not back yet. Okay, well, I'm going to get started here. All right, just make sure you guys have your cameras on so I could do attendance. All right, so, oh, this is a daunting statistic. 1 in 5 people in the US have an STI. They affect both women and men, but typically women have more complications just kind of due to our anatomy. This could mean like cervical cancer, issues with fertility, pelvic inflammatory disease or PID, ectopic pregnancy. So we'll kind of dive into more of those things. And some of these can be transmitted during pregnancy as well. So we'll talk about that. So some groups that are at high risk for STIs would be youths in general, but African American youths, abused youths, homeless youths, and then gay, lesbian, bisexual, transgendered youth. So any kind of young person is more likely to participate in more risky sexual behavior or have more sexual partners or kind of shorter relationships to where they're kind of bouncing around to more partners than what somebody older may be. That's not necessarily true, but you know. All right, so some factors that are placing teenagers at risk. So we talked about anatomy. Females, unfortunately, just were more predisposed to infection. Teenagers have that kind of feeling of invincibility, that part in their brain isn't quite developed all the way yet. They're more likely to participate in unprotected intercourse and then have partnerships of limited duration. And then also just obstacles kind of navigating the healthcare system. And maybe they don't have a parent that they can have that relationship with to reach out to say, hey, I'm having these symptoms. Can I go get checked out? You know, there's a lot of fear and embarrassment with that. And it's just hard to navigate the healthcare system even as an adult. So the CDC kind of has classifications for these infections and they kind of group them together. So infections that are characterized by vaginal discharge would be like yeast infections, which is not considered an STI, but I just wanted to put it on here because it talks about it in your book. And then CDC also kind of has this all lumped together, but I just want to make sure you guys know that yeast infections are not STIs. Trich and then bacterial vaginosis. So bacterial vaginosis is one of those also that's not like a classic STI, but the more that we've kind of researched into it, we do think that there maybe is a male factor component, but bacterial vaginosis is something that only affects women, but we're starting to find a connection that men may be carriers. And then infections characterized by cervicitis, so inflammation of the cervix, so gonorrhea and chlamydia. Infections that are characterized by genital ulcers would be genital herpes simplex or HSV, and then syphilis, which you can have what's called a chancre, which we'll talk about, which is an ulcer. Vaccine preventable STIs, so we have hepatitis A, B, and C, and then HPV. And then we have ectoparasitic infections, things like pubic lice and scabies. Okay, so let's talk a little bit about yeast infections or candidus. So there are lots of different species of yeast. And like I said, it's not really an STI. It is a normal inhabitant of like the mucous membranes, but sometimes we can get like an overgrowth and it alters that pH in that environment. Most women will experience at least one yeast infection in their lifetime. How this typically presents is a lot of itching or pruritus, vaginal discharge that's thick, white, and curd-like or like cottage cheese consistency. Sorry for anybody who likes cottage cheese. It can cause some soreness, burning. The burning is usually because the skin is irritated. And then like when she goes to urinate and that urine touches that skin, it causes like a burning sensation. Redness, swelling, painful intercourse, so that dyspareunia, and then that external dysuria because the urine hits that skin. Risk factors, pregnancy is a big one. Our immune system is lowered during pregnancy, so we're just more likely to get all these things. Use of oral contraceptives that have high estrogen can also cause you to get more yeast infections. Certain antibiotics, like broad spectrum antibiotics, those people with diabetes that's not well managed, like blood sugars that are higher, obesity, use of steroids or immunosuppressive drugs, HIV, wearing tight restrictive clothes, and then some trauma to the vaginal mucosa, like with chemical irritants or like douching. So how we diagnose this, we can see white patches that are visible on the vulva or the vaginal walls. The mucosa is going to be red and irritated. We're going to see that classic discharge. And then if we take a sample of that discharge and we put it on a microscope slide and we look under the microscope, we see what are called hyphae, which this is kind of what it looks like under the microscope. So that's called a wet prep, when you put a little sample on a slide and you add certain solutions to it. We treat this with, if it's over the counter, you can use something like Monistat. There's like a 1 day or a 7 day. I always tell my patients, do the 7 day. The 1 day does not cut it. You can get a prescription for Terazol, which is a cream that can be inserted vaginally, or a pill, a prescription for Diflucan. Usually the dosing is a 150 milligram tablet, and you either get 1 tablet or 2 tablets. So. Our nursing management, so things that we can teach our patients who are getting maybe repetitive yeast infections, encourage them to wear cotton underwear. It's more breathable. Avoid any kind of irritants or scented products. So nothing scented should be down there. Nothing should be inserted internally, like no douching, no like scented products whatsoever. Try to reduce dietary intake of simple sugars and sodas. Have good body hygiene. Super absorbent tampons and douching, I mentioned that. And then if it's somebody who's exercising a lot, making sure that they change out of their sweaty clothes, take a shower, will also help. Okay, and then bacterial vaginosis or BV, this is really, really prevalent. It's just abnormal growth of bacteria in the vaginal area. About 50% of women don't have any symptoms. It can be transmitted sexually, which is something kind of newer that we've just kind of figured out. Risk factors would be multiple sex partners, douching or using any kind of those fragrant products, not using condoms, things like that. So it's caused by an alteration in that vaginal flora. How it presents is usually like an off-white, gray, or green discharge. It has a very specific odor. It is kind of a fishy odor, especially after intercourse. It can cause some itching and irritation, and then dysuria, just because once again the skin is irritated. So then when you urinate, that urine hits the skin and it hurts. Complications. So if you are pregnant and you have BV, it can cause preterm labor. It can cause premature rupture of membranes. That's what this PPROM means: preterm, pre-labor rupture of membrane. So your water breaks early. It can cause an infection of the sac around the baby, the water sac. That's called chorioamnitis. And it can cause endometriitis. So the endometrial lining can become infected. And then pelvic inflammatory disease. So just kind of an infection in the pelvis. Okay, so we talked about the discharge, the odor. We can do a little wet prep with this as well, so we can get a sample of that discharge and look under the microscope, and we'll see what's called clue cells. These are fuzzy without, they don't have clear borders. The cells have like kind of fuzzy borders around them. So those are clue cells. And then how we treat this is oral metronidazole or Flagyl. It's usually a single dose of 2 grams, or we can do 500 milligrams twice daily times 7 days. That's what I saw most often. You have to be careful with this medication. Tell your patients that they cannot consume alcohol, even something like vinegar, because it causes nausea and vomiting. So making sure that they avoid alcohol during the entire treatment. There's also an applicator if they want like a vaginal medication. So you can use metronidazole gel or Metrogel, and that is inserted vaginally for 5 days. Another option would be clindamycin gel that can be inserted vaginally. And right now we're not treating male partners, but like I said, we are researching that. And I think eventually we'll get to the point where we are treating male partners. All right, trick. So trick, these are these cute little protozoans. So you can literally see them moving under a microscope. This is an STI, so it is sexually transmitted. It's not reportable. So reportable, there are certain STIs like gonorrhea, chlamydia, syphilis, HIV that are considered reportable, which means that when we get that diagnosis in the office or in the hospital, we as nurses have to fill out a paper with the patient's information, the diagnosis, how we tested, what we treated them with, and then we send that information to the health department and they track that. And then they also will contact any sexual partners, and they don't break HIPAA, but they say, you know, you may have come into contact with someone who got this diagnosis. You need to go seek treatment. So it's a way to help us know kind of what's out there and hopefully control the spread of that disease. Okay, so trick, this is a common parasite of both males and females. It can live on wet surfaces like towels, toilet seats, and swimsuits. Pretty rare to get it from that, but it can. Men are mostly asymptomatic. Women may have like a heavy gray-green frothy discharge. It can also have an odor. It can cause preterm labor if you're pregnant. It can cause pre-labor rupture of membranes or your water breaking early, or low birth weight babies because you go into labor early. And then postpartum endometriitis, where that endometrial lining gets infected. It does increase the risk of HIV transmission. So any kind of infection can increase other infections. How we diagnose this is we can look under the microscope and we can see these little guys moving around. A lot of times when we look at the cervix is friable. Friable means that when we put that speculum in and we look at the cervix and maybe do a little swab, like a little Q-tip, the cervix starts to bleed. That means friable. When it bleeds really easily, it's really irritated. And then you'll see that frothy discharge. You'll have itching usually and some tenderness, redness, and then the patient may also have some lower abdominal pain, pain with urination, pain with intercourse. Am I recording? Okay, good. Couldn't remember if I pushed my record. Okay. Our treatment for trick is going to be Flagyl, so metronidazole, 500 milligrams BID for 7 days. We can also do metronidazole 2 grams orally in a single dose. And then there also is this tinidazole as well. So what I see most often is Flagyl. This is the only class of medications that we know for sure has been effective against trick. So if you have allergies, then it may be something that you're sent to infectious disease to come up with a different treatment plan. So our nursing considerations, so just like with any of these STIs, treating these sex partners is always a challenge. You know, those aren't our patients, only the person presenting to us is our patient. So we want to encourage them to let their sex partners know, but you know, what happens after that, we don't know. But we do recommend that our patients come back in about 3 months to be retested because a lot of times they are reinfected. So even though that they've been treated, their sex partner has not, and they just get reinfected again. We also try to do a full panel STI because, like I said, you're more likely to have other infections as well. So we'll check for HIV, syphilis, gonorrhea, chlamydia, all of them. And then we do recommend abstaining from sex during treatment and making sure your sex partners get treated. And then, you know, we're always talking about safe sex and using condoms. So for pregnancy treatment, although metronidazole crosses the placenta, it's a low risk to the developing fetus. So kind of one of those things that's risks and benefits. So there's more benefit to treating mom than to let her have this infection. So that's kind of how we look at any kind of medications in pregnancy, risks and benefits. Does it benefit more than it causes any kind of potential risks? Okay, chlamydia. This is the most common bacterial STI in the US, and a lot of people are asymptomatic. It is the leading bacterial cause of blindness in the world. So this is why we give that erythromycin gel to newborns, the goopy eye stuff. Because if mom had been exposed to gonorrhea or chlamydia, then if baby were to be exposed to that, it can cause blindness. Like I said, many are asymptomatic. Men may have some like swelling in their urethra or some like irritation. Women may have some swelling on their cervix or their fallopian tubes. This can lead to PID or pelvic inflammatory disease, which we'll talk about. When you have pelvic inflammatory disease, you can get scar tissue and it can scar the fallopian tubes, and so then you have issues with tubal pregnancies or ectopic pregnancies because of all that scar tissue. You can have issues with preterm labor or premature rupture of membranes, and then that neonatal blindness. So some risk factors, like I said, being an adolescent, being a man who has sex with other men or having multiple sex partners or a new sex partner, any kind of unprotected intercourse or other types of sex using oral contraceptives, being HIV positive if you're pregnant, and have a history of other STIs. So how we diagnose this is we get a culture. Usually we get a culture from like the vagina or the penis, or we can also check from urine as well. We can send a urine sample. If they are symptomatic, we're going to see maybe some abnormal discharge, some swelling, some dysfunctional like bleeding or abnormal bleeding. All right, how we treat chlamydia, we can use doxycycline if they are not pregnant. So we can do 100 milligrams BID for 7 days, or we can do a single dose of zithromycin, or we can use Levaquin, 500 milligrams once daily for 7 days. We mostly, at the office I worked at, we did azithromycin. We do like to bring these patients back in 3 months to do a test of cure, so to retest them to make sure they didn't have an exposure again. We do recommend abstinence during treatment, so for about 7 days or so, and then making sure their sex partners get treated. This is a reportable one, so we do tell the health department about this diagnosis. So our nursing considerations. So we're going to encourage STI testing, and we're going to discuss safe sex. Okay, gonorrhea. So this is the second most commonly reported infection in the US. It's highly contagious. It's also reportable to health departments. It is exclusively transmitted via sexual activity. Our nursing assessment, so some risk factors would be low socioeconomic status, urban living, single status, inconsistent with barrier, contraceptives or condoms, younger individuals, multiple sex partners. How this manifests, most people are asymptomatic, may have some abnormal discharge, may have some dysuria, some swelling, maybe some abnormal bleeding in between periods. This can also lead to pelvic inflammatory disease and like all of that scarring and everything. We do a culture, so either a vaginal culture, or we can also do a urine sample. And then same thing, this can cause issues to infants during birth. So we have that erythromycin ointment that we'll talk about when we get to newborn chapters. Okay, so treatment of gonorrhea is Rocephin. So it is an IM injection of Rocephin, 250 milligrams. We also treat for chlamydia. Even if they had a negative chlamydia, we still treat for chlamydia just because the co-infection rate is so high. So they get a dose of Rocephin and they get azithromycin. Or they get doxycycline, or I'm sorry, they don't get doxycycline if they're pregnant, they would get azithromycin. And then same thing, in 3 months, we do a test of cure. So we bring them back in, retest everything. If gonorrhea goes untreated, it can actually spread to other areas of the body, like the joints, the skin, the heart. It can really cause a lot of issues. And I didn't realize that, how it can spread other places. So we have to be really careful with gonorrhea. We have to be careful with all of these things, but. Okay, and another common one, way more common than people realize, is genital herpes simplex, or HSV. Most people have been exposed to HSV, so 1 in 5. Doesn't mean that they're going to have genital sores, but they could still have the virus, exposure to the virus. So how we diagnose this is a culture. So if they do have a sore that has fluid, we get a sample of that fluid and we send it off to the lab. You can do a blood test. I do not recommend doing a blood test because, like I said, most people have been exposed to the virus, so a lot of people will come back positive, but they will never have an outbreak. So I don't think that's a great way to do the test, because this particular diagnosis is a really difficult one to have with your patient. Even if they've never had an outbreak before, they will lose their minds. Like, this is probably the diagnosis that I've spent the most time on the phone with patients, crying, screaming, losing their minds over this, even if they've never had an outbreak, and they never will. So I do not recommend the blood test, but if you have an actual lesion or sore, you can get a culture and get an actual diagnosis. There are 2 types, like HSV1, HSV2. Most people associate HSV1 with like cold sores and HSV2 with genital sores, but either one can go either place, especially with like oral sex. So if you have a sore on your mouth and you perform oral sex, that HSV1 is now transmitted to the genital area and vice versa. Treatment is the same no matter what. So Let me see if I have maybe treatments on the next one. So this is a recurrent lifelong viral infection. So it can rear its ugly head from time to time, and you can have outbreaks. Usually that primary episode, that primary outbreak is the most severe and prolonged. These patients are so incredibly uncomfortable to the point where sometimes they have to be hospitalized due to the discomfort. A lot of times they have these terrible sores, and then they're so painful that they won't urinate because the pain of the urine touching the sores is so extreme that they will withhold fluids. They will become dehydrated. It's just so terrible. What I would tell my patients is to fill up a bathtub. I would have them sit in the bathtub and urinate that way. And that way the urine is completely diluted in the water, and then they don't have to restrict any fluids, and they can empty their bladder and know that it's not going to hurt. So it's just such a painful thing. That primary outbreak is just so awful. You can have fever and chills and nausea and vomiting from it. Usually the subsequent recurrent infections are not like that. And a lot of these patients will go on to take medications to suppress that virus to help prevent further outbreaks or to lessen the outbreaks. So common medications that we give are acyclovir, Valtrex, or valacyclovir. So those are something that can be taken with outbreaks or can be suppressive therapy that they take every single day to try to suppress that virus and prevent outbreaks from occurring. So some nursing care of genital ulcers or genital sores. So we want to abstain from intercourse during the prodromal periods when the lesions are present, or if we feel like one is coming on. A lot of patients will have like kind of a tingly sensation, or they kind of know that one is about to present. So we want to avoid intercourse during that time. Wash hands with soap and water after touching the lesions. Use comfort measures, so restrictive clothes, cotton underwear, or maybe no underwear, urinating in the water, lukewarm sitz baths, air drying, anything that would offer comfort. And then of course like ibuprofen and Tylenol. Cold compresses, making sure that they're using condoms, and just letting their other healthcare professionals, know of that diagnosis. Okay, syphilis. So this is a curable bacterial infection if treated early. It can be a very serious systemic disease. Bacteria enters the mucous membranes, and there are different stages to syphilis that we'll talk about. Syphilis can cross the placenta during pregnancy, and it can cause like congenital malformation. So we do need to be very, very careful. So stages. So your primary stage is when you can have this sore. It's called a chancre. It can be anywhere on your body. This one just happens to be on this person's mouth, but it can be anywhere. This is a painless open sore. Very classic painless open sore is a chancre syphilis. Kind of relate all of that together. You can also have swollen lymph nodes, but really a lot of people, like depending on where your sore is, people don't even realize that that's what's going on. It could just be a sore, that they don't really attribute to anything. And then secondary, once it kind of goes on a little bit farther, then that person will get flu-like symptoms. They can get a rash on their trunk, palm, and soles, have issues with hair loss, swollen lymph nodes. And then if it still is not recognized in the latency period, they don't really have any manifestations, but it would show up positive on blood work. And then if we get all the way without treatment to tertiary syphilis, this is where we can have life-threatening heart disease and neurological disease. It can cause irreversible neurological damage. So it's something that if recognized early, we can treat and it's totally fine. But if we get to the point of tertiary syphilis, not good. We're going to have heart disease, brain disease. There are lots of different blood tests that you'll see come up for this. This is something that we test for in pregnancy see a lot. So you may see it listed as an RPR or a VDRL or a treponemum. There's all kinds of these names, but it's all syphilis. Okay, so for treatment, the only approved treatment is penicillin. And there are a lot of patients that have a penicillin allergy. So if they have that allergy, a true allergy, we would have to put a referral into infectious disease, and they have to go to infectious disease to, what's it called, where you get small doses of, somebody help me out. You get like small doses of the medication until you're able to handle the full dose. I always forget what that's called.
Microdosing?
Yeah,
Is it microdose?
yeah, but there's like a better way to say it. But yeah, so they do like increasing their tolerance. There's something I'm thinking of, but basically you have to get to the point where you can get that full dose of that medication to be truly treated. So infectious disease kind of takes those patients on. But anywho, so it is an IM injection, and usually the amount is enough for 2 injections. So it's not super comfy to get that. Same with like the Rocephin for gonorrhea, kind of an uncomfortable injection to get. A lot of times we mix that with lidocaine because it hurts. In your book, it does mention some other treatment options, but the CDC does not recommend those treatments. So penicillin is like the gold standard. And then we do want to follow up in 6 to 12 months to do retesting, just to make sure there wasn't exposure again. And this is reportable to the health department. This is just saying that syphilis is kind of complicated. So that's really all that you need to know about it. Okay, so I've mentioned PID or pelvic inflammatory disease a few times here. So pelvic inflammatory disease is just kind of like an umbrella term. So it's an ascending infection that gets up into the reproductive tract. Most commonly, it is caused from gonorrhea or chlamydia that's gone untreated. And then it causes different symptoms of swelling in those different areas and irritation in those different areas, and then scar tissue can form. So a lot of times it's in the fallopian tubes that you have that scar tissue and that adhesion. So then if that woman later on goes to become pregnant, and as that egg and sperm that have now started make an embryo and travel down into the uterus, they can't get to the uterus because of that scar tissue in the fallopian tubes, and the baby implants in the fallopian tube, and now we have an ectopic pregnancy, which is a medical emergency. It also can just cause infertility in general because we can't even make it to that point either. So pelvic inflammatory disease is just a tricky one to diagnose. It's a tricky one to treat because it can present with kind of vague symptoms until you kind of figure out what the diagnosis is. So here are some symptoms: lower abdominal tenderness or adnaxal, like off to the side tenderness, cervical motion tenderness. So when you're getting a pelvic exam, if they move your cervix, it's really tender. Abnormal discharge, a temperature. If they do blood work, they're going to have an elevated C-reactive protein, which just means that there's some inflammation in the body. They may have positive gonorrhea chlamydia culture, painful urination, painful periods, nausea, vomiting. So they're all just kind of vague symptoms, depending on kind of how this person presents. So a lot of times this will just be diagnosed based on lab results in a physical exam, but not one test is like 100%. If we do get, gonorrhea or chlamydia that comes back positive, obviously we need to treat the sex partners and then treat that infection. If this person is pregnant, we are doing screening throughout pregnancy for a lot of these STIs. Women under the age of 25 are going to be at greatest risk. So it's kind of the same things that we already talked about. Okay, so how we treat this. So for some women, they are really, really sick from PID and they need to be hospitalized and need to be on IV antibiotics, whereas some people can be sent home on oral antibiotics. So we do the ceftriaxone or Rocephin, and then they get doxycycline and metronidazole, and then it's just dosed based on if it's IV or oral. But the ceftriaxone is a injection for your ambulatory patients.
Megan, can I interject for a moment? Okay, so Tony put in the chat, she wanted to know if once chlamydia was treated, can pelvic inflammatory disease stay and be a lifelong thing? I wanted to say that if somebody keeps getting chlamydia or gonorrhea repetitively, it can become a problem. The more people continuously get STDs or STIs, it can become a problem, and pelvic inflammatory disease can be a problem and create more risk for infertility, and create more scar tissue and create more problems for them in the long run. So yes, it can create more of a lifelong issue for people. That's again, and I know I've said this in the past when I did lecture previously, this is something we want to maintain when we do have these people in the office and when we're treating our patients. We want to create that environment where we, educate our patients and create, the opportunity to offer them the barrier methods, teach them that they need to, monitor how many sex partners they have, and just keeping up with themselves. So yeah, making sure they have their.
Yeah, I think the important,
Go ahead.
Oh, sorry, Nicole. Go ahead. Oh, I was just going to say, I think it's important that yes, like gonorrhea and chlamydia are treatable, but like you were saying, if you have repetitive exposures, it can cause lifelong issues because you've developed that scar tissue. So it's not that you have that pelvic inflammatory disease long term, but you have the aftermath of it. So the pelvic inflammatory disease caused scar tissue that doesn't go away. So then it leads to those other issues.
Sorry.
No, that's okay. You're fine. Okay, let's talk a little bit about HPV. This is another one that I made a lot of calls for HPV, and people just really lost their mind on this one. But it's so common. It's the most common viral infection in the US. 80%, honestly, it's probably higher than that, of all sexually active people have been exposed to HPV. I would bet that it's even higher than that. But there are certain strains of HPV, and there are over 200 different strains, but there are, I want to say 14 high risk strains that are linked with cervical cancer. So those are the ones that we want to watch out for. Doesn't mean that because you've been exposed to HPV 16, HPV 18, HPV 45 that you're going to get cancer, but you're at higher risk for getting cancer. So that's why we do pap smears. That's the whole reason we do pap smears, is a hopefully preventative measure before that HPV has a chance to kind of fester and change those cells and become cancerous. Because HPV, like cervical cancer, is not something it happens like that. It takes years for that to develop. So get your pap smears, ladies. Okay, so our risk factors are going to be unprotected sex, smoking, multiple partners, if you're younger, like a younger individual, or you're immunosuppressed. There are some strains, not all, some strains of HPV that can cause genital warts as well. So that's what you're seeing here. These are called condyloma or genital warts. They can grow anywhere. They can be managed with medications or burnt off. They're very friable, so they bleed very easily. But not all HPV causes genital warts either. So HPV in general, it is a virus, so there is no cure. So there's not like a medication or an antibiotic that we give because it's a virus. Abstinence is the only, 100% prevention. Treatment is going to be just directed on at what's going on. So if you have genital warts, then we can help to treat those warts by, chemically removing them, burning them, whatever. If you have precancerous cells, we're going to remove those through processes like a LEAP procedure. If anybody who's had an abnormal pap and then you have a biopsy, and then sometimes they have to go in and actually remove those precancerous cells before they get a chance to become cancerous. So, anyways, so we do have a vaccine for HPV, Gardasil. It's a 3-series vaccine. It can be started as early as age 9, I believe. And then I believe they've approved it all the way up to age 40 something now. It's been around for a little while, so the age range has gotten larger. So even somebody who's had exposure to HPV and is in their 30s, like they should still get the HPV vaccine because, like I said, there's over 200 different types, and the HPV vaccine covers some of those most dangerous types. So it gives you some protection against those. Cannot get this in pregnancy, so it's kind of one of those like preconception things that try to get these patients to complete this before pregnancy. It's 3 injections over the span of at least 6 months. So you get one, and then 3 months later you get the second, and then 3 months after that you get the third. But you can also get them years apart too. Like if you had a vaccine and you forgot to go for your second one and it's now been 2 years, you can catch up and pick that right back up. So therapeutic management, our primary prevention of vaccine and education, treatment of those lesions or warts. What else? I think we already talked about all that. A little bit about hepatitis A and B. So hepatitis A isn't an STI. It's spread through the GI tract, like fecal oral route. We don't have a whole lot of it here. We've got a vaccine. It is highly contagious, but self-limiting. And this hepatitis A does not cause liver disease. Whereas hepatitis B, you've probably heard more about, especially being in healthcare. This is something that we can be exposed to through saliva, blood, semen, menstrual blood, secretions, needles, razors, toothbrushes, anything like that. And it does cause or can cause chronic liver disease and failure. We do have a vaccine, as I'm sure all of you know, because you've all got it. And then what else? So if you do have hepatitis B, your symptoms would be flu-like symptoms, right upper quad pain where your liver is, fever. This is something that we do screen for in pregnancy. And then we offer the very first vaccine when babies are in the hospital, as long as the parents consent to it. Okay, ectoparasitic infections. So these would be things like scabies and pubic lice. So this is mostly just, they're very easy spread person to person, get a lot of itching. And we treat this with certain like shampoos or creams. And then you want to wash all of your linen, all of your bedding. All family members in that home need to be treated. This is really common, especially in our patients who are living in maybe a community household or something. So not unheard of by any means. So there's a little pubic lice. And then HIV. So we discovered HIV in the 80s, which is not that long ago. That always blows my mind. As far as just kind of who's affected, so 2 million children globally are living with HIV. And then in the US, about every 10 minutes, someone becomes infected. It is transmitted by sex, needles, exposure to blood, breast milk, or it can be transmitted through pregnancy. Fetal and neonatal effects are generally fatal if we don't have the diagnosis as soon as possible and get treatment as soon as possible. So risk groups are going to be women, low income, African American, Hispanic women, gay and bisexual men. We diagnose this with blood tests. There's different tests that are approved by the FDA. It also has stages. So that first stage, the seroconversion, where you have that acute infection, this is about 2 to 6 weeks after the exposure, you have kind of flu-like symptoms. And then 3 to 12 months, that's when it would actually show up in your blood work. So it doesn't initially show up. Like if you were to go, like, let's say you had your exposure, you're kind of in this 2 to 6 week range, you're not feeling great, you got your blood test, see if you've been exposed. It's not going to show up that you've had exposure to this virus yet, but you are still contagious. So it can take up to 12 months to actually see the detectable antibodies on a blood test. That's why it's so dangerous, because you are contagious that entire time. And that's also why we test pregnant women at the beginning of pregnancy, the middle of pregnancy, and at the very end of pregnancy, just in case they had exposure at any point during that time. Anyways, so the virus begins to replicate and the immune system begins to fail. To get the diagnosis of AIDS, that is when the CD4 cell count falls below 200. So our normal count is 450 to 1200. So once we get to 200 or below, now that diagnosis changes to AIDS. As that viral load increases, that's when more symptoms would occur. You have profound immunosuppression, then you have all these opportunistic infections that can occur. We do have really good treatment for this, antiviral medication. However, the medications are hard to adhere to because of the side effects, and there are multiple drugs that must be taken every single day for the rest of this person's life. So a lot of people are not compliant because of the side effects or because of maybe the cost or just the amount of having to take them and remember to take them. Anyways, so it's just a tough diagnosis, but we have made great strides in treating people. Okay, a couple practice questions here. So the nurse is caring for a female patient in the clinic recently diagnosed with HPV. Upon assessment, the nurse is likely to note which of the following?
Warts.
Yep, they may have a cluster of genital warts. Like I said, not always. Most HPVs do not cause genital warts, but of those symptoms, that's what we would see with HPV. All right, a client is diagnosed with chlamydia. Which instructions is most important for the nurse to include?
Take full course of antibiotics.
Yep. You got to take the full course. Return of symptoms worsen. Some people don't have symptoms. So we got to take all those antibiotics and then come back in about 3 months for that test to cure. All right, a client with untreated syphilis is at the highest risk for which complication? So what can happen with
Neurologic.
Yep, neurologic
See?
damage. Yep, so neurosyphilis. Yay, safe sex for everybody. Oops. Let me pull up this little chapter 7 here. Okay, so I wanted to just go over a few of these benign disorders that most of you are probably somewhat familiar with. So there's my little cuterus again, but now he's a little sad, or she's a little sad. So let's see what's going on. Okay, so just briefly, pelvic organ prolapse. It's just as terrible as it sounds. So basically, this is where some of your pelvic organs can start to fall down. I want to say fall out, but the muscles that hold them in place aren't holding them in place like they should, or the ligaments that typically hold things in place are not holding them in place like they should. So because this affects your pelvic organs, that includes your bladder, your bowels, your uterus. So with that, these patients can have issues with urination, defecation, and sexual activity. The most common types are going to be a cystocele. So that's when the bladder starts to drop into the vagina. Rectocele, so the rectum kind of sags and bulges into the vagina. And enterocele is where the intestines come down. And then, oops, I put urine. I did not meant to put urine. Uterine. Goodness gracious. All right, uterine prolapse. So the uterus starts to kind of like turn inside out and come out the vagina. So there are different stagings of prolapse. Stage 0 would be like no prolapse at all the way to a stage 4, which is like the most severe. So just to kind of give you a little idea, so this is the normal pelvic structure where things are in the places that they're supposed to be. This right here is showing you a rectocele and a cystocele. So here's your uterus in your vagina here. The bladder has started to prolapse. So the back of the bladder is now like entering the vaginal canal. And then same with the rectum here. So it's being pushed this way out the vagina. So these patients can feel these bulges in that area, and it can make things obviously very uncomfortable. Enterocele, so you have this person's bowels that have started to come down into the vaginal area, and then a uterine prolapse. So our uterus, which is supposed to be up here high, has now started to fall down. So the symptom that most often I would receive calls about, I did a lot of triage, so I talked to a lot of patients on the phone. They would describe this vaginal bulge or pressure. So, or it felt like a balloon down there. This could cause some stress or urge incontinence or urinary frequency or hesitancy, just like kind of issues with their stream of urine, or they're not feeling like they're completely emptying their bladder or their bowels. They can have incontinence, urgency of defecation. So like all of a sudden they gotta go, or they can't hold it in. They could have issues with sex and achieving orgasm, or pain with intercourse, lower back pain, issues when they would try to insert a tampon, it would just like come right back out. So not pleasant symptoms at all. So some risk factors would be somebody who's had a lot of babies. So that's multi-parity, means that you've had a lot of deliveries. Parity is like how many babies that you've had after 20 weeks. Multi would be multiple. And we'll talk more about these this new vocab, but that's what multiparity means. Increasing age, so the older you get, the more likely you are to have an organ prolapse. Menopausal women, obesity puts a lot of pressure down there. Any kind of reproductive surgery, if you have a family history of prolapse, if you have a connective tissue disorder, so something like Ehlers-Danlos syndrome, where you your connective tissue, like you're more stretchy, things stretch out more easily, you're more flexible. Increased abdominal pressure from like chronic coughing or chronic straining. Somebody who's had like chronic constipation is always like pushing and bearing down. They can be more likely to have organ prolapse. Or lifters, somebody who's lifting heavy weights. How we manage this, depending on the grade of the prolapse, you can do pelvic floor therapy with like a pelvic floor therapist. So there are certain maneuvers that they can help you work on. Hormone replacement. Dietary and lifestyle modifications. There's something called a pessary, which is a device that can be inserted vaginally that holds things kind of up in place. And then there's surgical interventions. You can actually have surgery to tack those different body parts back in place, essentially with mesh and other things. Okay, so some benign growths, polyps. So polyps are typically pretty small. They're almost always benign. They're little mucous membrane growths. They can be on the cervix or endocervical inside the lining, endometrial. The cause, we don't really know. Sometimes they can become infected. It could be like chronic inflammation, issues with like an abnormal response to estrogen levels. There could be like a blood flow issue, so you have this like congestion there. Symptoms, a lot of times they do not have symptoms. Maybe, if anything, they have some spotting, spotting with intercourse or spotting in between periods. And how we manage this is we can remove these little polyps a lot of times in the office. If it's on the cervix, sometimes they can just pull them right off. If it's more internal here, they may need to use some like in-office anesthesia and go ahead and remove them. And then a lot of times they'll give an antibiotic afterwards, just in case there is infection. Another common benign growth are fibroids. So these are like fatty tumors composed of smooth muscle and fibrous connective tissue. You may also see them called myomas or leiomyomas. I typically call them fibroids. They can grow on the outside of the uterus, inside that muscular part, or into like the endometrium. So depending on where they're growing, they have a different name. So like this is a submucosal fibroid. This is a subserosal fibroid. So they can be pedunculated. There's all kinds of crazy names. You guys don't need to know all of that. But these tumors are estrogen dependent. So they happen in our reproductive years. Once you reach menopause, they no longer grow and are an issue. But during our reproductive years, they respond to all these changes in estrogen. They can be very small, pea size, all the way up to very, very large grapefruit size. What can happen and when these can become problematic is like during pregnancy. Let's say you have one of these submucosal, but it's a grapefruit size, so it's taking up all that space inside the uterus, and now you also have a baby taking up all this space. So it's very uncomfortable. It can cause premature contractions because the uterus is just getting so stretched out and so full. So it's just really, really uncomfortable. So there's actually some pictures of what they look like. So there is a genetic predisposition to fibroids. They are more common with African American patients, those with hypertension, those who have an early menstrual cycle or like start their period early, those with vitamin D deficiencies, increased alcohol consumption, smoking, chronic stress, someone who's never had a baby, so nulliparity means that they've never had a baby after 20 weeks, those with diabetes and obesity. So these patients may have chronic pelvic or lower back pain. They can have changes in their menstrual cycle, which can cause heavy bleeding, which can lead to iron deficiency anemia. They can have issues with constipation, infertility and miscarriage, dysmenorrhea, like painful periods, heavy periods, painful intercourse, urinary issues. Because it can push on all those different areas. It can push on your bowels, it can push on your bladder. We manage these with hormones, or we can do something called a uterine artery embolization where we cut off blood supply. We can do what's called a myomectomy where they actually go in and surgically remove them. Hysterectomy, we just take the whole uterus out, or this magnetic resonance focused ultrasound to kind of shrink them. Okay, another thing, the fistula is not as common here in the United States, but this is a huge, huge problem in other countries and specifically like the continent of Africa. This is a really, really big issue. So this is an abnormal communication between the female genital tract and the urinary system or rectum. So we have an opening between those areas, whether it's the rectum or the bladder into the vagina. And so then you will have urine or feces in the vagina. A lot of times this is from trauma, whether that's like birth trauma or perhaps like genital mutilation. Very, very dangerous. Obviously, these women are at huge risk for abscesses and infections, and it needs to be surgically corrected. Another common thing that we can see quite a bit from an office perspective are Bartholin cysts. So our Bartholin glands are two glands that sit near the vaginal opening and they help to lubricate during intercourse. Normally they're really small, they're like pea size. And sometimes the ducts can get backed up with that fluid, that lubrication, and then it becomes infected and they can get really, really large, like a golf ball size, very uncomfortable. And then that fluid isn't able to drain. So these patients will, they'll tell you that they feel like there's a golf ball down there. They can't sit. It's so painful. They'll come in and we'll see that they have one of these Bartholin cysts. So a lot of times we will do, oral pain meds like ibuprofen, Tylenol, sitz baths, just to kind of help with this discomfort. And then in the office, they can actually do like an I&D. So they will, incision and drainage is what that stands for. So they will use a scalpel to open it up and allow it to drain. And sometimes they will place what's called a ward catheter. So they'll put this catheter into where the cyst is. There's a balloon here, and then it helps that fluid continuously drain as that area is healing, and then eventually they'll come in and get that ward catheter removed, or sometimes it just falls out, and then we'll put them on antibiotics. But some women get these a lot. They're just more predisposed to Bartholin cysts. They're very uncomfortable. Another common thing that we see are ovarian cysts. So these are fluid-filled sacs that form on the ovary. A lot of times these are just follicles. So remember, a follicle is what houses that immature egg. If you have a whole bunch of these follicles that they aren't really doing a whole lot, these are, we all have ovarian cysts throughout our cycle, but sometimes they just get a little out of control. But that's a really common one, is a follicular ovarian cyst. You can also have a corpus luteum cyst. So that corpus luteum, kind of the same thing, it turns into a cyst, or these, I don't even know how to say this, theca lutein. I'm not quite sure what that is, but follicular are kind of the most common ones that I've seen. Corpus luteum, I see those quite a bit too, like after ovulation. But a lot of times we don't have symptoms with ovarian cysts. Like I said, most of us have ovarian cysts. We don't even know it. Our treatment, if it's, really mild, it's kind of a wait and see. Our body just kind of, it will degenerate on its own. But every once in a while, these ovarian cysts can get very, very large. And with that, it can put that patient at risk for ovarian torsion, or an abscess or infection. A torsion is where the cyst is so large that it weighs down, gravity will pull it down, and it pulls that ovary down and it twists on itself. And so then it loses blood supply. So that's very, very dangerous, and you can lose your ovary. So that's something that we need to watch out for. And those people, we would do surgery to actually remove or drain that cyst. And then I mentioned a few times polycystic ovarian syndrome. That's a little bit different because it's an endocrine condition. But with PCOS, you have a whole bunch of these follicles that aren't going through those normal stages of like maturing an egg. So they're just all these immature little follicles that aren't really functioning well. So it creates all of these little cysts. And then with that, you also have all these endocrine signs and symptoms, and issues with like glucose intolerance and abnormal hair growth and obesity. And not always, this is not everyone with PCOS, but it's kind of a complex disorder. So it's not just a bunch of cysts. So here's just like an example. So here's like a little follicular cyst on the outside of an ovary. And then here's like what a polycystic ovary looks like. A lot of times they'll call this like a string of pearls because it just looks like a whole bunch of little circles. So this is what a normal ovary looks like. It's like follicles that are all at kind of different stages of development, where this is just a whole bunch of follicles that aren't really doing a whole lot. Oh, apparently that's my last slide. Okay, I told you that was a sweet one. Short and sweet. Okay. So